Morning. We will go ahead and start, open our multidisciplinary advisory committee meeting. We will first have agenda item number 1, the roll call.
Ms. Buller?
Here.
Dr. Gecken?
Here.
Dr. Nunez?
Here.
Ms. Pulaski?
Here.
Ms. Felt?
Here.
Solicitor?
Here.
Sullivan?
Here.
Accessory?
Here.
Waterhouse?
Here.
We have a quorum.
And on to agenda item number 2, public comment for items not on the agenda. Any public comment in the room? Any public comment on WebEx?
Yes, and I will announce for everyone, if you would like to make a public comment, you will look for the hand icon, typically at the bottom of your WebEx screen. Although if you're logged in on a mobile device, that hand icon might be behind the 3-dot other options. And you will click that to raise your hand. We'll take comments one at a time. Each person will have 3 minutes with a 15-second warning. And we ask people to speak only once per agenda item. So our first request is from Stefano Di Concetto. I've sent you a request to unmute your mic.
Yes, good morning. My name is Stefano Di Concetto. I'm sorry I cannot turn the camera on. I am a veterinary anesthesiologist practicing in California, and I wanted to bring to your attention a concern that the anesthesia community has, for which a colleague and I contacted the board back in December for advice, and the first recommendation was to participate in this session. The concern regards the ability of registered veterinary technicians to practice ultrasound-guided regional anesthesia, which is an advanced and quite complex procedure. And at the moment, there is no clear rule as to whether this type of practice is something that registered technicians should be able to perform. So I don't know exactly how to proceed, and if it is better for us to maybe give a presentation at the next meeting in June. In that case, I would need advice on how to submit a request.
Thank you for your comment. And I don't know if the board would like to reply or...
No, just for clarification, this is for public comment only. It's not for open dialogue, so we have no reply right now.
Thank you. And are there any other requests for public comment for items not on the agenda? You can look for the hand icon and click that.
I would just like on the previous person commenting, and we'd like to get his correct spelling of his name so that we might be able to contact him if needed.
And that will be included in the attendance report that
Okay, great.
Solid will send. Thank
Can
you.
Can I clarify? He said ultrasound guided regional anesthesia. Okay.
And I do not see any further requests for comment. I will turn the meeting back to you, Chair.
On to agenda item number 3, review and approval of committee meeting minutes. First one from October, and we have 2 different versions, the full minutes and also action minutes. So let's do the full minutes.
I just want to provide a little bit of clarity here of why you're seeing 2 different versions of meeting minutes. So as you all are aware, the full meeting minutes are very, very long. There's also some inherent challenges when it comes to meeting minutes other than how long it takes to actually put them together. When you have meeting minutes, they're not supposed to be transcription meeting minutes. It's supposed to be summarizing the discussions and always capture the motions and the votes on the motions themselves. But when you summarize discussions, you run the risk of missing something or potentially putting things in there that maybe a member doesn't want in there. You have members who said, well, I didn't say that, when maybe they actually said it, but they didn't mean it. And you have all sorts of things in between, and you just run the risk of more information causing more problems. And legally, we don't have to have all of that information in there. We had talked about this, I think, when I first started about potentially moving to action minutes. And at that time, it was decided we'll do action minutes, actionist minutes, to where it would cover the motions, but then any discussions that were not part of the memos would be captured, thinking that that would be less time consuming and less voluptuous minutes. But as you can see, it's still very, very long because we have a lot of discussion, which is great. We have a lot of public comment, which is great, but it's very long. And so when you look at the difference between true action minutes and full minutes, it just for the MDC meeting October alone is 32 pages versus 6 pages. And so we recommend action minutes. You do still have access to all of the materials. You'll be able to go right to the video to see who said what and when and watch it for yourself. And so we provided that to you. I did run this by Tara before she went on leave and with Elizabeth to make sure there's no legal requirements that we're missing, and there are not. And so we wanted to bring this to you. One of the questions I get a lot is, well, what if we don't have access to those videos at some point in time? There you'll see the bottom of the action minutes. It does have a disclaimer that these are videos are controlled by third-party links, the hyperlinks, and they're not considered part of the official board record. But also if we, for whatever reason, if it does no longer available on YouTube, we do have access on our end to that video if we do need to access it in the future. So I just wanted to put that all out there of why you're seeing 2 different versions. And what we're asking from this board, this NDC, is to approve all of them, because it's really going to be up to the board what the board wants to keep as far as the format of the minutes. But if you have preferences or thoughts on the difference between full minutes and action minutes, we'd love to hear that and provide that to the board tomorrow.
So for the October 14th minutes, the long version, anybody have any corrections or additions? We approve these separately?
You could do it, you could do them all at once if you want. You could do
Okay.
them in one motion. But
Okay,
I'm hoping that we get some kind of feedback to you on if you have a preference.
okay, shall we go to the action minutes? Dr. Nunez?
I have a comment on my preference. Typically, when I'm preparing for a meeting, I just watch the YouTube videos in my car during my morning and evening commutes. So the action minutes are sufficient for me. That's just my preference.
Duly noted. Anybody else have an opinion?
And I agree, because I'm watching them anyway. We all know I watch them. And so I think that the action minutes are sufficient because I believe that the true intent of minutes, you're not going to get from reading them, regardless of how they're written. And so I believe that the action minutes are better and they are more precise, and you can never get the intent of what somebody means in a written word. So I think that it's better to have an action minute.
Kathy?
Yeah, I just want to agree with all of that, and I think the links are very sufficient in the action minutes. If you haven't watched it, to go back to, if you want to remember, it's a cleaner way to look at. We do so much in these meetings. It's just the board. Sometimes, 32 pages is kind of a short one. We've had them 60 pages
Yeah.
before, and when you have so much activity, it's hard to find them. So the action minutes is a cleaner way of finding what were the votes and on what subject. So thank you.
Yeah, I'm on a couple of other organizations and I don't know of any that have complete minutes like this. So I think this version, the action version, or even shorter versions are much more effective and I think legal.
Anybody else like to voice an opinion?
And I think the videos give full disclosure to the public, especially since we do not discuss items outside of hearings, committee meetings, with the exception of subcommittees. So it does provide transparency to the public. which is a good thing.
Okay, so we should proceed on to the action minutes from October 14th. Anybody have a comment for this? Comment or additions? Since long version was okay, hopefully that would be the same for action. So I entertain a motion.
Can I just move to approve minutes for October?
Thank you. A second?
Second.
Okay. Any public comment in the room? Any public comment on WebEx?
This is the moderator. If anyone would like to make a comment on the minutes from the October 14th meeting, you may look for the hand icon and click that to raise your hand. And if you are on a mobile device, that hand icon might be behind the 3-dot other options. Each speaker will have 3 minutes with a 15-second warning, and we ask people to speak once per agenda item. Are there any comments on the October minutes? I do not see any hands raised. I will turn the meeting back to you.
Thank you. So call for the vote.
Ms. Buller,
Aye.
Getkin,
Yes.
Dr. Nunez,
Yes.
Ms. Pulaski,
Yes.
Schultz,
Yes.
Dr. Solocito,
Yes.
Sullivan,
Yes.
Ms. Esri,
Yes.
Dr. Waterhouse.
Yes.
Motion carries.
Okay, on to the January 20th action minutes. Any comments? Is there a motion?
I will move to approve.
Second.
Any public comment in the room? Any public comment on WebEx?
This is the moderator. If anyone would like to make a comment on the January 20th minutes, you may look for the hand icon and click that to raise your hand. Each speaker will have 3 minutes. Any comments on the January minutes? I do not see any raised hands. I'll turn the meeting back to you.
Thank you. So call for the vote.
Ms. Buller,
I have to abstain because I was unfortunately absent in January.
we will hold that against you. Getkin. Dr. Nunez,
Yes.
Ms. Pulaski, Ms. Feltz,
Yes.
Solocito,
Yes.
Dr. Sullivan, Ms. Esri,
Yes.
Dr. Waterhouse.
Yes.
Motion carries.
Agenda item number 4, a presentation regarding the high-quality, high-volume spay-neuter services and mobile animal sterilization hospital MASH clinics. So which one are we going to do first?
So we have representatives from UC Davis, Dr. McCobb and Dr. Bennett here. And the MDC subcommittee who's working on this topic thought it would be good to hear from the experts when it comes to the high quality, high volume spay and neuter services to help guide the decisions made at the board and the recommendations potentially from the MDC as well, to understand the difference between a typical spay and neuter and a high quality, high volume spay and neuter. And then also ask them their opinions when it comes to whether or not the high quality, high volume spay and neuter process can be done safely in a separate designated area versus a separate designated surgical room. We asked for their thoughts on that. And then after that, we have Dr. Bushby and Dr. Brown, who are also going to opine and share their experience and knowledge on the topic as well. So right now we can turn it over though to Dr. Bennett and Dr. McCobb.
And we
Thank you.
do have, oh, yes, so Dr. Bennett, do you see in the top right section, there is a take control button? Or alternatively, there is at the bottom a share button and you
That's
can
what
share.
I have.
Yes,
Yes,
you're welcome to share your screen at this
Okay.
point.
And I'll just mention, Dr. McCobb is, as you can probably see, logged in and may be able to listen, but she's in an event where she won't be able to participate. So I'll be presenting for both of us today.
Yeah, I mean, I can just introduce
sorry.
myself if you want, Dr. Bennett. So I'm Emily McCobb. I'm a board certified anesthesiologist, and I'm a professor and endowed PetSmart Charities endowed chair of accessible veterinary care at UC Davis. Prior to this, I oversaw a spay neuter clinic at Tufts University for 15 years. So Dr. Bennett and I just put together a little bit of background, but I'm happy to answer any questions, especially as it pertains to anesthesia and pain management for spay neuter. But I'm going to let Dr. Bennett kind of run the presentation because I am out of the office and not really available.
Okay, can you hear me and can you see the sharing screen? Excellent.
Yes.
All right, so,
Yeah.
and glad Dr. McCobb is, is able to give some comment here. So let me put this in presentation mode. Thank you for the invitation and thank you for setting up our task, as I understand is to kind of give you some history and some examples here of high volume spay neuter and some of the forms that it takes. So let me go ahead and put this into presentation mode. Hopefully that is giving you the entire screen. And we're obviously joined by some others later, so some of this may have some overlap, as particularly with Dr. Bushby's information. And you can have our contact information there if you would like to get a hold of any of us following this. I'm Dr. Jennifer Bennett. I am the Director of Shelter Medicine Access to Care at the Correct Shelter Medicine program, which is adjacent to the UC Davis School of Veterinary Medicine. I lead a team of outreach veterinarians that supports students and practicing veterinarians in this profession. And we are have various levels of involvement with high volume spay neuter, both individually and as support to teams that are providing that service through their organizations and through their shelters. And that includes both in-shelter clinics and MASH style clinics. I have been a shelter veterinarian for about 18 years and have participated in both of these styles and also in setting up clinics myself. So happy to be presenting to you today. So just want to kind of quickly go through, and I can slow down or speed up as we have time. This is just an example to kind of give you an idea of what these clinics look like. This is a picture here of a MASH style clinic example from the Rural Area Veterinary Services Group. They're a subsidiary of Humane World for Animals, formerly HSUS. And you can see this is one I participated in a couple of summers ago.
Dr. Bennett, I'm so
Yes.
sorry to interrupt. It looks like it went out of presenter mode, so it's making your presentation pretty small. Are you able to go back? There we go. Thank you so much.
Thank you for letting me know. I'm on my smaller travel laptop and normally have a couple of screens. So thank you for letting me know that. So this is just an example, like I said, of what these look like in practice, at least for this particular organization. But I wanted you to have that concept in your mind while you're seeing, hearing and seeing what we're going to talk about. You can see there are different stations where different things are happening, from induction to surgery to recovery. All right, so HQHVSN, the acronym that doesn't sound like a word, but is actually used most commonly for this area of surgery. The practice, the history of this particular surgery and the further establishment of clinics and guidelines really has been decades in the making. High volume clinics early established in the 70s. I actually worked for the city of Seattle, and we have one of the oldest public spay neuter clinics there that was established in the early 80s and was one of the first in the country there as well. HQHVSN is the phrase that was coined by the task force for the advancement of spay neuter in 2008. So it is an industry standard definition and term that is commonly used by practitioners to mean a particular surgical practice with particular contexts. And it's been taught in veterinary schools for the last several decades. And again, there's a task force that we'll talk about a little bit further that has been actively involved in writing and revising guidelines to set standards for this practice. I don't know if you can see this particular textbook here. It might be a little bit blurry, but there is a published Wiley textbook, High Quality, High Volume Spay and Neuter in Shelter Surgeries, that has this definition, as well as the MASH definition, which I know we've been discussing as well in subcommittee. So MASH stands for Mobile Animal Sterilization Hospital. That also has a very particular definition and is used in a particular way to mean temporary surgical spaces that are typically coming into areas with low access to care, a non-regular surgical practice or outlet for spay and neuter services in that committee. And these independent MASH programs are responsible for all aspects of running the clinic, very similar to what you saw in that previous picture. And there's very specific established protocols and methodology for often accomplishing several hundred in several days' time to bring spay neuter services to those underserviced areas. And there are examples later that I will show of organizations that have been doing this also for multiple decades, internationally as well as in the United States and in our state. The history of the Veterinary Task Force to Advance Spay Neuter is under, and you'll see ASV in here for any of you not familiar, that is the Association of Shelter Veterinarians. They play a prominent role as a organization that brings together task force and guidelines in our shelter medicine industry. And they convened in 2006 to define what this area of surgery is and to create legitimacy around this area of practice, very deliberately, with practice guidelines, training and recruitment strategies, looking at the impacts of having spay neuter access. And you can see the composition of the task force there. 22 veterinarians comprised the initial group, including all of those specialists. And then we have in JAVMA, our Journal of American Veterinary Medical Association, the first guidelines here in July of 2008. And those were the guidelines. There are other guidelines. This one is for spay neuter programs, but they are published as shareable articles for the veterinary community to refer to. And so you can see the authorship there includes multiple veterinarians from that task force, as well as Dr. Bushby, who I know we're going to be hearing from later.
Might be a different between.
All right. 5 years later, there was a reconvened spay neuter task force to update these guidelines. This is a periodic practice. Initial guidelines typically are updated then at a periodic basis. And you'll hear that we are actually once again entering that period here. So funding and support by major organizations that work to bring shelter medicine and access to care nationally. And again, a board of multiple veterinary specialists to convene and to review and update these guidelines. So you can see here the differences and the additions between the original 2008 and all of the sections that were updated and added with several hundred references with the revised version in 2016. And these are all available for any of the committee members to find publicly. And we're going to talk a little bit about what some of these sections cover, just so you can have a sense of the depth and the thoughtfulness that has been put into this particular area of surgery practice and the ways that the committee thought about how each of the aspects of high volume spay neuter should be addressed through protocol. So the Association of Shelter Vets recognizes HQHVSM programs as a critical component of efforts to reduce shelter intake and euthanasia. It is continuously supporting the development of these programs and guidelines, as I mentioned, and committed to delivering high quality care to each animal. And that high quality aspect and part of the coining of this definition, as Dr. McCobb and I were talking earlier about, really was developed in the face of early critics that were concerned about what was happening in these surgical spaces. I know when I was at the City of Seattle's early shelter, that clinic had I found lots of early supporting materials that were put together to really convince the public and the clients of that clinic how the same sterilization and the same methods and the same sedation and so forth were used just at higher volumes and as a devoted practice. So there was a lot done initially to provide reassurance to the public and separate from whatever preconceived notions they may have had about shelters and surgeries at the time. This is a position statement here from the Association of Shelter Veterinarians, talking about the high quality, high volume spay neuter program statements and the sentiments that I just mentioned. And there is the location you can access it. And again, you'll see some familiar authors there with the reference for this position statement. It's really, high volume spay neuter clinics really serve as a gateway for veterinary care, often for those who do not have access to regular veterinary appointments or for multi-purposes. High quality, high volume spay neuter is done inside of animal shelters, as well as in other formats like the MASH style clinic to serve both community and shelter animals, depending on the context. All right, so delving into the individual sections of the guidelines, just to give you a sense of what types of sections are in there and what is addressed for these particular surgeries. This is one of the sections, patient care and clinical procedures. Patient transportation services is addressed, record keeping in detail, vaccinations during surgery and around the surgical process, how we handle and house patients before and during recovery, how we manage infectious disease control and preparing for emergencies and follow-up and emergency care, which has lots of forms depending on the community and how often the clinic or the visiting MASH staff are in that area. Those are all set up and very much purposefully. Patient care and clinical procedures are defined. There are sections on record keeping to comply with federal, state, and local laws and to help record each individual animal's individual events and information. This is just an example of a sort of a clipboard form because there's, by definition, many animals coming through. So standardized forms and a full record of everything that happens, as many of them also receive additional services like vaccinations or parasite prevention, things that are around that. I volunteer typically annually with the clinic I showed you in the beginning, Rural Area Vet Services, and they often are combining a community clinic with the spay neuter procedures. So they get very good at having very efficient record keeping for all the services in order of what's happening with the patients, as well as areas for any additional observations or plan modifications, things like that that come up that need to be addressed as part of the total animal health and observations. So very in-depth paperwork, but very efficient paperwork because they're typically trying to stick to clipboard and single sheet. There's a section for patient care and clinical procedures, for follow-up and emergency care situations. These clinics must establish regular policies for managing their complications and their emergencies, and how they're going to re-examine or address these for each individual clinic situation, where they're referring or how they're seeing these animals or how they're having them seen if it's not possible. And in the event, of course, of patient death, that they're monitoring and have a plan for necropsy and follow-up for morbidity and mortality information and follow-up to inform the program. Surgical care section includes the operating environment description and attention to asepsis, instrument preparation, patient prep, surgeon prep, and sterile instrument and a sterile instrument pack for each patient. So you can just see some examples there. So lots of details for the surgical space, and it's important to note there that there are different definitions for the types of surgeries that are done between cats and dogs. Cat neuters in particular are not considered sterile procedures in the guidelines, which is something I wanted to point out. All right, operations management section. There is a definition of the steps from intake to discharge, and I have one example from a MASH clinic here later. I'll show you that. Oops, sorry, I got my dog under me. That is looking at the patient care really from the very beginning to the end. It's very much like following a pathway, and very organized, and lots of protocols that guide each step of the way. They're extremely efficient, and I'm a big fan of checklists myself. If you're a checklist lover, these style clinics are really up your alley, because they're for folks that do the same thing all the time, so that nothing is missed and we don't forget things that are become routine, similar to like air traffic control. Lots of checklists, lots of protocols for each step. And a section for results, so that we can monitor how things are going to reduce errors and really increase patient outcomes and improve time and cost efficiency, which is also part of preparing for these surgical procedures. So data collection is also something that the ASV is very interested in, and many folks who have done research in this area have also helped to put together. There is a recommendation in the guidelines for systematic collection of data so that we can characterize and track patient outcomes and see how overall the outcomes are for this field, which also, as I mentioned, includes any adverse events. There is regulatory and legal considerations, and the guidelines are meant to be a supplement, not replace those. I do have some information just to share, and I can also share later with the board to send along information about sort of differences across states. But those things are considered in the guidelines, and of course, a call to vets and administrators to comply where there are differences to the more stringent criteria. This is just an example here of MASH organizations. So that subset of high quality, high volume spay neuter that actually uses the MASH style model. Some of these you may be aware of. Just quickly mention Animal Balance. They have international roots, but also work in states, including California. Greater Good clinics are also across multiple states and employ teams for these MASH clinics. Operation Catnip is led by Dr. Julie Levy and her team from the University of Florida. Rural Area Vet Services is now housed under Humane World for Animals, and they primarily service Midwest and Great Plains states where they're often on tribal lands, where they're not beholden to particular state regulations and are often working with hundreds of miles between veterinary service access. So these are often the only vets that are seen in those areas. Shelter Outreach Services based in New York, and then just an international one to mention that's been around for a long time, Spay Mexico is another example. This is just a quick example of some information that I have to share from the Animal Policy Group. Katie Jarl, who is the Vice President of Government Relations, and a colleague of mine sent this over. They're able to do cross-state comparisons of legislation and compare and contrast what's currently happening. So I thought this would be interesting for the committee to see sort of a spread summary of states that actually have fixed facility standards language, only 15 of them. Some, including California, have both fixed and mobile facility standards language. And then there are quite a few, and in fact, the majority that do not have language for facility requirements. And then the remainder of this document goes into what each of these states have and as they compare and how they compare and contrast. So as you can see, there are many states who are outside of the facility requirements in their regulations and are therefore often pioneers in some of the areas that we're talking about. Okay, so I just mentioned some of the organizations, wanted to kind of briefly show you a little bit more about the history and the volume and the experience that these organizations have. Shelter Outreach Services has nearly a dozen, last I checked, veterinarians that work with them and are affiliated with the students from Cornell and Cornell's Shelter Medicine program. Work through this organization. They're up to almost 200,000 spays and neuters to date. Been around for almost 2 decades, and since June, there it is, 2003, based out of Ithaca, New York, and they perform the MASH style clinic to open up access to care in the greater New York area, but also have worked with and assisted groups in Vermont, Wisconsin, Ohio, and other communities to open up this style of practice. So lots and lots of data and examples from this group to draw upon. Operation Catnip, I mentioned, they've been around since 1998. They have, I think, now exceeded 100,000. Their latest goal now says they're getting close to 200,000 as a goal for cat spay and neuter. And again, if you look here, probably a little hard from where you're seeing this, but we can make these slides available. The prep, recovery, and surgery is happening in this space here, and this is affiliated with Dr. Julie Levy and the University of Florida Shelter Medicine Program and Surgery Training, where they have a focus particularly on feral cats and trap neuter release surgeries. This is the slide I wanted to share, just showing you, this is Spay Mexico. They have done about 90,000 surgeries in the last 2 decades. In a different country, obviously, where they have similar concerns with lack of availability of these services. They have a broad goal for many more by 2030. And if you you don't have to zoom in on these, but essentially these are all their lists of checklists and stations as you walk through. And I just liked the visualization of how this flow chart works. It's very much a flow through pathway for how these clinics work to have efficiency and maintain protocols between the groups. All right, so what's next for high quality, high volume spay neuter? I alluded to the task force having a new iteration, and ASV is currently has, I don't know that they forced the third task force, but formed, I think there is a third task force that's going to be revising the spay neuter guidelines now again in 2026. So this will be a 10-year update. And as we've chatted about before, this is a great opportunity to hear this information from folks that are working on these topics now in California, to have that input and feedback for those on the task force. Dr. Emily McCobb is one of those, and the full task force is not has not put forth their guidelines yet, but I presume many of the previous authors will also be returning. And so this is an opportunity to review and update content. A lot of the questions that are asked and of interest here will be considered in this task force, including updating and including additional guidelines for MASH style clinics. Very interested in the environmental considerations for surgery spaces, as was mentioned. There has been discussion about what the requirements are and should be for surgical spaces, particularly when it comes to minimizing contamination and where those come from. As you can see, most states do not have separation of surgical space in they don't have those facility regulations. And so there's a great interest in the task force of understanding where those come from for the states that have them and why, and are they really those factors that contribute to reducing complication, or are they actually more associated with, as many suspect, with surgeon preparation and sterile technique? As you can see, these clinics are done without those, and there are hundreds of thousands of successful cases that have gone through. Just updating the definitions for the guidelines is a priority, and looking at what is aseptic versus sterile and non-sterile procedure considerations and the classifications between the procedures. And then, of course, we're interested in, and the task force is interested in the feedback and the input from groups like this and from constituents and our shelter veterinarians who are out there actually practicing in this field. Some resources provided here by Dr. McCobb for some of the book chapters and guidelines that I mentioned that you can peruse or download later. Most of these are available as PDFs or journal articles. And at the bottom, there is a newer publication that's a response to WASAVA guidelines that was put out, I believe, in 2020, early 2025, talking about more international topics related to spay-neuter access and procedures. And that's what I have for you. So we have a question slide here just to pause for any additional questions or information that is of interest.
Thank you, Dr. Bennett. That was very informative. I have a question. Do you use the terms HQ, HVSN, and MASH interchangeably, or do they really refer to different things?
MASH is used in my circles as a subtype of high quality, high volume spay neuter. So it is high quality, high volume spay neuter performed in a MASH style setting, if you will. And it can also be performed in a shelter surgery room, for example. So I use it as a subset of high quality, high volume spay neuter.
Okay.
But the actual definition is more about the environment. And I don't know if our other speakers want to.
Yeah, I would agree.
That's the
All
updated
MASH,
yeah.
all MASH is HQ HVSN, but all HQ HVSN is not MASH.
Okay.
Thank you.
Thank you for that, Dr. Bennett. I think that what we're looking to do is potentially come up with a definition of what a high quality, high volume spay and neuter is. And forgive me because it was quick and I was trying to read your slide, but it doesn't seem like it actually gave a definition for what high quality, high volume spay and neuter is, rather than saying that there's spay and neuter services that are performed in a MASH clinic, and then you had a definition of a MASH clinic. So is there a more concrete definition of what high quality, high volume spay and neuter means? And we're looking more so like what makes it high quality, so some kind of definition of quality, and then what's high volume.
Mm-hmm.
Yeah, I mean,
Right.
I'm hoping that Dr. Bushby will speak to that when you hear from him, because he was around when they originally coined the term. But I don't think the task force had ever sought to put the parameters around the definition that you guys are looking for. But it's sort of defined as efforts to reduce pet overpopulation. So there's sterilization programs with an aim towards ending pet population, but that can look very different in different contexts. And so that's why we don't have specific numbers or parameters around it. In terms of what is high quality, the implication of the guidelines is that if you follow the guidelines, the result is high quality operations and procedures.
Can I make a comment on that too? As someone who does practice in a shelter environment, HQ, high quality, high volume spay neuter is more of a technique. The MASH style is more of a physical location of how it's physically laid out. So high quality, high volume spay neuter is already practiced by veterinarians, right? So that's more of a technique, as if it's like, what makes a high quality spay? Just leaving out the high quality, high volume, right? Like if you're asking a general practitioner, what makes your spay quality? You can't really answer that because it's technique driven, right? But MASH itself, I think, is the thing that we need to put on the table, because the MASH style, which is the physical clinic layout, is what is right now in direct contradiction to the minimum premises requirement. So I think it's more of the MASH that we are talking about, and not the actual technique of high quality, high volume that's in contradiction to our specific task.
I'd like to comment on that. Actually, what we're trying to do is try to have a clearer definition, just because if this is going to be placed in legislation, it has to be defensible, right? Like, so we need to at least quantify, just like if we are going to create like the minimum standards that we have, we need to specify at least what is acceptable, to be qualified as a high volume spay neuter service, because we cannot just say somebody's 5 spay neuter per day is already high volume for somebody compared to these experts that could do a lot more.
And what you're saying is that the so what they're saying, I believe, is that there is no right now number in place for us to work with as far as definition goes, that they officially from the.
Yes.
Correct.
I think there is no legal definition
Okay.
as of yet for
Thank you.
high quality, high volume spay
Correct.
neuter.
I'll just add to that, as a practitioner and someone who has worked as and hired, it is typically in relation, while there's not a specific number attached to it, it's typically in relationship to what you would expect someone hired into a general practice to perform, which is often, again, there's a range, but typically several a day, or maybe a handful a week, half a dozen a week in a typical general practice. And the positions for veterinarians who are either working in shelter or whatever MASH environment, whatever environment they're in, if it is specifically advertised for high quality, high volume spay neuter, they will typically state how many surgeries they're looking for. And those can often be 25, 35, 50, 60 a day if you're talking cats. So it's quantities of 5 to 10 times higher if you want to roughly have an idea. But as Dr. McCobb said, there has not been a technical definition.
Yeah, if I could just chime in for 1 second. We run, at the ASPCA, the Community Medicine Department runs several different kinds of spay neuter, high quality, high volume spay neuter clinics, meaning we have stationary clinics, we have mobile clinics, and we have run MASH clinics. And the same doctor, the reason why it's so hard to give you an exact number is that the same doctor will be able to do a different number of surgeries per day depending on where they're doing them. Are they mobile, or are they stationary, or are they MASH? And also, as Dr. Bennett just alluded, depending on the composition of the patients, are they 80% dogs and 20% cats? Well, then the number is going to be smaller than if there were 80% cats and 20% dogs. Sometimes also the volume will vary depending on the time of year. We are heavy into pregnant cats right now. And so the number of surgeries that can be done, if every cat spay is a late term pregnant cat spay, the number might be lower at this moment. So giving a definition of an exact number that qualifies as high quality, high volume is very, very difficult and dependent on the surgeon, the venue in which they're doing surgery, and the specifics of the patient population they're working with.
Yes, unfortunately, we work with a bunch of attorneys and they demand that we define these things. Yes.
To clarify, we love our attorneys.
Yeah, we love our attorneys.
And the problem is that there's entities who are asking for an exemption to the current law, which the current law requires that aseptic surgery be performed in a separate surgical suite. And so we need to know, if you're asking for an exemption, who we are talking about, which is why it has to be defined. It can't just be anyone who's doing high quality, high volume spays and neuters without a definition. We don't then know how to differentiate those who need to have a separate surgical suite for all the other aseptic surgeries that are being performed versus the subset of high quality, high volume spay and neuter clinics. So it's very important that we are very clear on who we were talking about. So we love our attorneys.
I was joking, obviously. Yes, we love our attorneys. They keep us honest. Yes. Yes, Dr. Nunez.
So when we discuss proposed regulations to address the definition of what high quality, high volume spay and neuter clinics are, we're also going to be discussing the facilities. But after hearing your presentation, I was wondering if there's other exemptions that may need to be made. And hopefully these are quick answers. The medical records that you showed were on a clipboard. Do they eventually get transferred to electronic medical records? And how long are they kept? What are the guidelines for that?
Different programs do that differently, but they would keep them as long as required by law. My program used to keep them for 7 years, just like any other records, and we would digitize them. And that's, I would say, fairly typical.
Yeah, same. I've seen a variety often start with a paper clipboard because there's often variations in access to, internet service in some of these areas, or just unreliability and the speed at which they can gather. I know I've asked this question myself in some clinics, and then sometimes those are scanned in or translated into the electronic version, but they're retained just the same as a traditional.
Okay, so it
medical
wouldn't be
records.
difficult to comply with current California regulations. And then the other question was, you mentioned that staff are assigned for certain task during the whole procedure, the whole conveyor belt approach. Do you follow the guidelines for restricted task? Like, so for example, only licensed DVMs and RBTs can induce anesthesia? And is there a determination of who is competent to perform these tasks? Or do you need exemptions for that?
So all of the clinics that I mentioned will speak on just sort of general terms, but California specific, obviously there's variations between state and whether they're performing them in on state lands or tribal lands and so forth. So I won't be able to speak to each individual organization. What I have observed in general, so just across states, is that there is typically a skills assessment and training that comes in. There's training manuals. Sometimes there's skills assessments that happen, particularly if there are particular techniques. But often these are professionals. Most of the time they're working as their typical profession, whether they're a licensed technician, licensed veterinarian, and they are either volunteering or signing up for these as shifts. Just like any other relief shift. So they're coming in as a hired professional if they are a licensed person. So the assumption is that they have already met their licensing requirements and they're following the extent of the licensure and what they're allowed to do by law. And there are lots of other positions, as you saw. So there are places for volunteers to be in other positions. It might be checking into the clinic or helping with laundry and various things. And those are often done by assignment for the clinic director. Each
but
particular place is different. Yeah.
I would just emphasize that in California, all the MASH clinics that I have been involved with or observed in California use California credentialed LVTs and California credentialed DVMs. And then they would, whatever duties those folks are restricted to, such as surgery for DVMs and induction for technicians, those procedures that are going on in California are in compliant with the Practice Act.
Yes.
Okay. And Dr. Brown, I think, could you actually introduce yourself?
Sure. So I'm Carolyn Brown. I am the Vice President of Medicine for a department at the ASPCA called Community Medicine. And we operate high quality, high volume spay neuter clinics in New York City, Miami, and Los Angeles. In Los Angeles, we operate the spay neuter clinic associated with the LA City shelter in South LA, Chesterfield. And we have mobile clinics. We are also in the process of opening a community veterinary clinic that will feature as part of it a high quality, high volume spay neuter clinic in Carson. So I would, just for our program, I would reiterate what Dr. McCobb said. Since we operate in different states, we follow the rules and regulations as far as what is allowed by uncredentialed people versus RVTs versus veterinarians in Los Angeles, following the California laws.
Okay, thank you.
We also just medical records wise, to chime in on that, we put our medical records, just for us, we put our medical records directly into an electronic system. So we do have electronic record keeping.
Okay. And you were talking about the different factors that come into play as far as how many surgeries a veterinarian could do in a day. I would think a huge factor would be the number of technicians, the number of assistants that you have.
Well, we staff depending on that, right? So yes, the number of technicians and assistants, the ratio of support staff to veterinarian does greatly influence the speed at which one can do surgeries and transition from surgery to surgery. And we staff, for us, we staff in a way that maximizes the surgeon productivity. So we have something like a 4-to-1 ratio support staff to each surgeon.
Are all veterinarians, like at a MASH dog clinic, are all veterinarians doing surgery?
Not
No, some
necessarily.
would be doing exams or anesthesia.
Okay. What other questions? Yeah. Kathy.
Thank you. Just a follow-up to Dr. Nunez's question on for the ones that use clipboards and what do you call it? The paperwork after a procedure. Does the owner take a copy of that away with them as well? Or are they
Typically,
provided?
yes.
Okay.
Typically, yes. A lot of them have it sort of generates that for them. As we move more into electronic medical records, a lot of us will do a separate printed discharge for the owner.
Okay, thank you. And then this is kind of in the weeds, but because you all have so many decades of experience doing these high volume spay neuters, and I think on one of the slides, it talked about a lot of data gathered, tracking patients after the surgery, see outcomes, et cetera. And I just wondered what processes, given the owner population is often rural, possibly unhoused, low income, must be harder to track them down after the weekend is over to see and what are your numbers? Do you have a system that you can gather a lot of data with to see about any post-surgical issues that may happen?
Yeah. And I would let Dr. Brown also speak to that because they actually have published papers out of that, but because they track all of that over time, thousands of cases. We recently added, texting, just like you would have in any vet clinic. So we're in contact with the clients by text, so they can get in touch with us because as Dr. Bennett mentioned, the guidelines require support for emergencies. So you have to tell them where they would go and you have to have quality improvement policies and track your M&M numbers. And so there's numerous studies where they've tracked the percentage of complications and compared it to other similar types of surgical programs. And then, there's so many numbers that if you see trends, you can address challenges as they arise. And then I would let Dr. Brown speak to that a little bit.
And Dr. Brown, before we do that, I guess Dr. Busby, there's a third veterinarian that would like to be involved in this.
So we have Dr. Bushby also on the line. And so Dr. Bushby, if you don't mind introducing yourself and sharing your thoughts on the topics discussed today.
All right, sure. I'm Phil Bushby. I'm a board certified surgeon. I've been involved in high quality, high volume spay neuter for over 30 years. It's scary. It's getting close to 40 now. I was one of the 22 authors on the guidelines that were published in 2008, and one of the 18 authors that were on the guidelines that were published in 2006. I've been on the faculty of the College of Veterinary Medicine at Mississippi State University for 48 years, and I've run their shelter program and their high volume spay neuter surgical instruction program, which now also includes continuing education opportunities for licensed veterinarians who often graduate from veterinary schools across the country having done a half a spay or maybe 1 or 2 spays and get out into private practice and don't feel comfortable doing surgery. And so now we've added a continuing education program to assist those veterinarians to become more confident and more capable in performing surgery. So what you're going to hear is a lot of redundancy, I think, between Dr. Bennett and Dr. McCobb and Dr. Brown and myself, and you might get tired of hearing some of the same things over and over again. But I do want to thank you for the opportunity to address the committee. I think it's very important that we be careful on trying to reclassify mass style spay neuter from aseptic to clean. I intend to address 3 basic issues. One is the phrase high quality, which we've already started to kind of beat to death a little bit today. The concept of creating an environment completely free of microorganisms, and the factors that will lead to introduction of pathogens during surgical procedures. And what I hope to conclude with, and it may be that we wait until the end when everybody's spoken, but with what I believe is a scientifically sound recommendation to deal with the surgeries that are performed in a mass style setting. One of the things I will be doing, though, is referencing comments in the memo that was sent out specific to this question that's being discussed today. And in the memo, one of the statements that's made is, since high quality is subjective in nature and could imply standard spay neuters are not of equal quality, the subcommittee recommends not including the term high quality in any definition. It goes on to say, using the term high quality may also mislead consumers into thinking that the board has determined that these services are higher quality based on set criteria. All right. So the committee is saying that high quality is subjective, but the 2008 and the 2016 publications define the guidelines and standards and techniques for high quality, high volume spay neuter. So high quality guidelines and techniques are defined, but they're defined in these very long and involved articles. They're not defined in a sentence or 2. Removing the phrase high quality from the definition may mislead consumers into thinking that the board has determined that these services, meaning the mass style or high volume, are of lesser quality than the services provided in routine private practices, in spite of the fact that specific guidelines and techniques are published defining high quality spay neuter. So you suggest removing high quality from the definition because leaving it may mislead consumers, but removing the phrase will also mislead consumers. All right. In another area of the memo, it says, while not defined in the Veterinary Medicine Practice Act, aseptic surgery is generally understood as surgery requiring a set of specific strict practices to create an environment entirely free of microorganisms, such as bacteria and viruses. Its primary goal is to prevent the introduction of harmful pathogens into a patient's body thereby reducing the risk of surgical site infections. And goes on to say, arguably, the moment the surgery is performed in an open space outside of a dedicated surgical room, the surgery is no longer free of microorganisms and harmful air pathogens. That's a quote from the memo that was sent out. The reality is that the concept of creating an environment entirely free of microorganisms is completely unrealistic. Regardless of all the steps to eliminate bacteria and other microorganisms from an isolated room with floor-to-ceiling walls, microorganisms are introduced into that room the minute an animal patient is brought into the room or the minute a human surgeon walks in. Both carry microorganisms with them into the room. Additionally, while there's a requirement for doors and walls, there's no requirement for a separate air circulation system or a negative pressure system to ensure that air is not circulated through other parts of the clinic into the surgical suite. So we've defined that for aseptic surgery, we have to have a separate room with a door and walls from floor to ceiling, ignoring the fact that air is circulating from the entire environment, perhaps the entire hospital. And so that air circulation that goes into that isolated room is also bringing harmful pathogens into the room, right? So whenever surgery is performed in an isolated surgery room, the surgery is no longer free of microorganisms and harmful pathogens. And if we believe it is, we're fooling ourselves. All right, so the focus should be redirected from the quality of the room to the measures used to minimize introduction of harmful pathogens into the patient's body. That's what those guidelines define. All right. If you compare a high quality, high volume spay neuter surgeon performing a cat spay in 5 minutes through an incision 1 centimeter in length, with a private practitioner performing a cat spay in 15 to 20 minutes through an incision 3 to 4 centimeters in length, which procedure would have the greatest risk of introducing harmful pathogens into the body? There's a fundamental problem, and we do this almost universally, not just in veterinary medicine, but kind of like the world. A fundamental problem is we tend to make decisions based upon what's easiest to measure, as opposed to what really matters. Code regulations, again from the memo, Code Regulations, CCR, Title 16, Section 2030, subsections G1 through 5, that requires a surgical suite to have walls from ceiling to the floor and a door. It's really easy to look at a room and determine if it has walls from ceiling and is isolated from other activities. But that's completely artificial. We resort to this simply because it's the easiest thing to measure. It's much more difficult to evaluate the quality of the surgical techniques, the size of the incisions, the length of time it takes to perform the surgery, and the amount of tissue trauma. But these are the primary factors that play a role in actually reducing the entry of harmful pathogens or allowing the entry of harmful pathogens into the body. So we seem to be stuck on this requirement, and I recognize it's the legal requirement of having a isolated room with walls from floor to ceiling and a door. But perhaps we should be more focused on, rather than creating reclassifications, maybe what we really should try to work for is defining standards that really have an impact, defining standards or regulations that really do matter in minimizing wound infection, minimizing complications. And I'm sorry, but putting walls up and closing a door is almost irrelevant. Almost, not completely, but almost irrelevant if you ignore the quality of the surgical techniques, the amount of tissue trauma performed during the surgery, the length of time the animal is under anesthesia and on the surgery table, and the skill and techniques of the surgeon. But we don't deal with that. We deal with, we have to have an isolated room. I'm not trying to step on toes. I'm trying to be realistic. I do have a recommendation that I would like to make to the committee, but I think it's best that we wait for that recommendation until after Dr. Brown has spoken and any of the other people that are in attendance want to speak to this entire issue. I have this fear, it truly is a fear, that if we remove the comment of the high quality phrase, and if we reclassify mass style high volume spay neuter as clean rather than aseptic, we will significantly harm and perhaps even destroy the one system that we currently have that provides access to care for low-income families, pets, or access to care for animals in tribal lands, access to care for animals in shelters. By removing high quality and removing and reclassifying, we could be doing a lot of damage that I don't think the committee wants to do. I certainly don't think the veterinary profession wants to see these activities be reduced or destroyed, especially when we're in an environment where everyone is getting more and more concerned about access to care. And, what I'd like to do is I can take any questions. And I would like to, at some point in time, when everybody's had a chance to speak, come back with a specific recommendation, which I think might be scientifically sound and might be acceptable to the committee.
So I think everybody, I think your comrades there have spoken. So maybe you can just go ahead and give us your recommendation.
All right, so the recommendation says to be consistent with the science behind high quality, high volume spay neuter. We recommend retaining the high quality component of this description and providing an exemption from the requirement for a separate isolated surgical room as long as the surgeries are performed consistent with the published spay neuter guidelines. It moves the focus from the room to the quality of the surgeries. If the board is more comfortable, they could also define a requirement for a specific degree of separation between the intake functions and the patient prep functions and the surgery areas within a matched facility.
And how far is that?
Pardon?
How far is that? What's the distance?
Well, that could be debated. And I'm gonna have, there's someone, I'm gonna have to close the door. I'm gonna be right back because there's a noise in my yard. So I don't know. I think that what the distance should be is something that can be discussed and resolved.
Okay. Okay.
Anyway, That's the recommendation.
Thank you.
So
Dr. Gaitkin.
can I ask a question while we have them there? Just looking ahead, because a discussion up here has to be some sort of parameter on high volume. I'm curious up there with the experts, would you consider a high volume spay neuter clinic to be on the volume dependent, if we had to choose one, on the output of the clinic of the day or the output of each veterinarian? I know when I have,
So we, on the committee that Dr. Solicito and I worked on, we tentatively defined it as 30 animals per day per veterinarian.
so my question is this: if I was one of those spay neuter, let's say there's 3 of us veterinarians and I am newer to this technique and one of the veterinarians is training me, I might not hit 30 myself if we're counting it per veterinarian. For me, the clinics I've been involved with is the intent of the total for the day and not per veterinarian. So I'm just curious with the panel up there, because we are the ones that have to discuss what high volume means, at least keeping high quality out of it. Is your opinion with the intent of a MASH style clinic, let's say, where you have
I mean,
three-
yeah, I largely agree with you, but speaking as a licensee myself, I am opposed to having a number on it, because if you just think about it, any teaching context, it's not about the number, it's about the techniques. And I think if you follow the guidelines, it's HQ, HVSN, and the number doesn't matter, because it also depends on how much time it is.
Yes.
And sometimes we have restrictions on the time, and sometimes we have restrictions on the space and personnel. And so you can do everything exactly the same, but it might be a lower number. I understand why you feel like there needs to be a number and that it's a way of ascertaining that it is for overpopulation, but there are just so many different contexts that might fall out of any particular number.
But then how?
But I want to know what
we-
my colleagues also think.
we're looking at exemptions here. So what do you say to a veterinarian that has a regular practice and he would decides, oh, well, I don't have to have a surgery room anymore because I make more money in an exam room. I'm going to turn my surgery room into an exam room and I'm just going to do surgery out in the treatment room. What do you say to that? So you have to have some definition here. If they want an exemption, why shouldn't everybody get that exemption?
And if I may add,
Need to be able to answer that question.
yeah, if I may add, based on the discussions that we've had on the committee, the reason why we're trying to establish a number is the fact that the exemptions being requested for high quality, high volume services, which would, I would say, I guess the high quality, high volume services needs to be defined with Dr. Gedkin's point that if somebody's training, that they're not going to be able to come up with like a higher number, but you would not rely on that trainee to dedicate that service, to be
No,
able
but
to
you
provide
could
high quality,
imagine
high
them using
volume.
the same space like they're using in the University of Florida, with that big open space, but with a much smaller volume. And then to the question of the general practitioner, it seems unlikely to me that they would be able to follow every other aspect of the guidelines and have it be considered HQ, HVSN in a general practice.
I think one of our wonderful attorneys, Ken, has a question. Oh, sorry, Elizabeth has a question.
Yes, thank you. This may be too technical, but it's based on something that Dr. Brown mentioned, that the numbers depend on whether you have 80% dogs versus 20% cats, or vice versa. Is there a way to define, is there a way to define the number based on the pet? Whether it's 30 or more dogs, 30 or more cats, rabbits. Alternatively, does a neuter take longer than a spay? Could you define it that way?
We do we do internally have formulas because we run 8 programs, and they each have differences. We do internally have formulas that we use, but what I would say is that, and we also hire, it's been mentioned a couple of times, training. We hire a significant portion of new graduates into our program. And when we look at the number of surgeries, we actually in our clinics look at surgeries per surgeon and do not expect new graduates or trainees to be able to do the prescribed number for a minimum of 6 to 9 months. And so I think you can say, and I would say if you had a MASH clinic, some of these MASH clinics are actually doing spay neuter for shelters to be able to do pre-adoption, pre-neuter adoption. And they may have a clinic that has a lot of pregnant dogs. And it's just me, I usually think of the minimum number of surgeries that a trained, experienced, high quality, high volume spay neuter surgeon should be able to do is 20 surgeries per day. That's my number. There are clinics where we have much higher numbers depending, but if you're looking for a baseline, and I think you would have to qualify that as a trained, experienced, high quality, high volume spay neuter surgeon.
Okay,
And
thank
if I
you.
could add to that, that 20 a day assumes a relatively normal distribution between cat surgeries and dog surgeries and between spays and neuters. That if you have this mixed population, dogs and cats, male and female, I think 20 would be a very realistic, although in many situations, the lower end of what would be considered high volume.
Okay.
But if you have 20 80-pound pregnant dogs,
Yes, all us veterinarians know. Yeah.
that's going to be a completely different story than
Yes.
having a relatively normal distribution dog, cat, male, female.
Right. We're just trying to talk averages here. Dr. Nunez.
I think the previous presenter may have misread the room as far as the direction that this committee is going. To operate these clinics, they're asking for exemptions to the Practice Act. And the reality is that we operate in a world of legislative analysis, analysts, wonderful lawyers, and 30-day public comment periods. And as Dr. Waterhouse mentioned, if we make an exemption for one specific group, then the rest of the licensee population will say, how come we can't have that exemption as well?
Yes.
So we have to justify these exemptions. We do recognize the importance of these clinics, these services, and we acknowledge and appreciate the high standards that your organizations have done a great job at establishing to make sure that the complication rate is minimized. We know that you can possibly provide aseptic environments anywhere, but there was some mention in some language about if we're not going to have walls and closed doors, then there should be assurances that the foot traffic is minimized, which makes sense, and that's reasonable. And also, there was also a mention of tents. So the surgical area may be performed in a tent, which also kind of makes sense. That would also minimize potential for contamination. Do you specifically have comments on what specific requirements could be established in these clinics that would be allowed, that would be not a burden on the clinics, but also would provide a level of aseptic environments? Your comments on foot traffics and tents.
Well, certainly minimizing foot traffic in the area where the surgeries are being performed makes total sense. It a little bit goes back to, could we define a specific distance between where they say the prep area and the surgical area? And I'm not sure what that specific distance would be, other than the greater the distance, probably the less of a tendency for contamination. What I really struggle with, though, is that the law focuses more on definition of facility and does not seem to be focusing on the quality of the surgery, the techniques used, all of these things that are defined, and I don't know how you do this I'm not a lawyer, okay? I don't know how you do this or convince the lawyers that a 20-page document that defines specific guidelines and specific techniques that are all encompassed in this concept of high quality, high volume. Following those guidelines is as important, and perhaps more important, than the room you're doing them in. And I don't know how to get.
I think we all agree with, I think we all agree
Yeah.
with that, tissue handling is an important skill to have. But we're still, trying to define and trying to determine these exemptions here. Dr. Sullivan.
Yes. When we're trying to do exemptions, we get into the legal issues of definitions. There's no way around it. And we already have a very clean way of taking care of all of this without changing anything. And that is to call the procedure clean surgery. We already have those regulations and those laws. I don't think there's anyone on this committee that is against this procedure when done correctly. And it sure would alleviate a lot of work that we would have to do because those regulations are already in place. And that's exactly what is happening in an open room that has air conditioning going on, where there's an animal being prepped for surgery with clipping of the hair, and that environment is not acceptable for a sterile procedure. And so if we call this a clean surgery, everybody can go ahead and do the work they're doing, and you would have the support of this board, this committee, this board, and the entire community. We could get on with our work. I don't see the need to have extensive exemptions that then create other obstacles for our work. So I think we need to go back to that and just have a clean page. But I'm not hearing any of that.
I have a question for the three of you. Would you have an issue with requiring the surgeon be in a tent? So just a pop-up tent that you provide, that you bring into this gymnasium or whatever facility it is?
That would create a very hot surgeon. I think that would really reduce airflow and create an environment where the surgeon being capped and masked and gowned would be incredibly uncomfortable. So I think while the idea is good, I think the reality of that would not be practical.
I agree with that.
Yeah, can I just speak to the why not just call this clean surgery? Can I speak to that point for a moment?
If it's quick.
Yeah, I can be quick. So one of the things that Dr. Bennett, I think, was getting at with her presentation is that, you know, high volume spay neuter clinics have been in existence for a long time. I started doing them in shelters in the 1990s. And at that time, this type of clinic that did rapid spay neuter surgeries was really frowned upon. The profession did not respect it. There was a lot of feelings about it not being high quality, which is why the guidelines and the term high quality are very important for us to be able to gain the respect and vanquish some of the skepticism about what we do in these clinics, that these procedures follow these guidelines. If we take these procedures and now call them clean procedures, different than other spay neuter procedures, that creates a, you know, when you say we don't want to call them high quality because we don't want to infer that they're more than other spay neuters, well, we also don't want to call them clean surgeries and imply that they're less than other spay neuters. And the reason for that, and I agree with the gentleman who just spoke, that that would be a really simple way to just get these clinics rolling. But in the long run, that may be very detrimental to MASH clinics, because one of the reasons why the guidelines and using the term high quality were very important is that it allowed these clinics to gain trust, not only from the public who brings their pets to us, but it allowed us to gain trust from organizations and funders and donors. And so diminishing these surgeries, calling them less than other spay neuters, may be the quick way right now to get them rolling under the Practice Act. But in the long term, it may diminish the accessibility of these services because there'll be difficulty in recruiting for them. Veterinarians will not want to work in a clinic that they think provides spay neuter that is clean and not aseptic. And funders, donors may feel that this is not the quality of service that they want to provide, even though it meets all of the guidelines. And so I would just be really careful about how we classify these clinics and what it means for the long-term sustainability of the clinics.
Okay, thank you.
Can I add one comment to that, please?
If it's 1 minute.
1 minute. I don't remember whether it was the June 1990 or 1991 issue of Veterinary Economics that had on the cover a title of an article that said how to keep a Humane Society clinic out of your community. And on that cover, there was a quote from a veterinarian who had made a quote in the article saying there is no such thing as half sterile, no such thing as half safe. Those of us that have gone through the battles, and believe me, the 1990s and early 2000s were battles in this profession. I can remember being called to the witness stand in defense of veterinarians who were doing high quality, high volume spay neuter, who were threatened with losing their license. In one situation with a veterinarian who, one of the charges against this veterinarian from the state board, not California, another state, was no veterinarian can do a spay through an incision that small and do it well. No veterinarian can do a spay that fast and do it well. No consideration whatsoever with the quality of what was being done, but every consideration was we want to shut these programs down.
I don't think anybody wants to shut the programs down.
But maybe probably nobody on the board or the committee wants to do that, but there are people, I'll bet you anything across the profession, there are still those people. We fought those battles through the 90s and early 2000s. We don't want to fight them again.
Okay,
Yeah,
thank you.
I'm
We
just
are
saying unintended consequences, not purposeful.
Right.
okay.
Right.
We're going to take a break right now, a 10-minute break, and we'll be back. Okay, let's get started again. We need to push on. And so does the board have any specific questions? The MDC, sorry. Does the MDC have any specific questions for our three presenters? Because we're actually going to discuss this in the next agenda item. So this is just trying to get questions to the presenters and information from them. Any other questions for them? If not, we'll open it up for, oh, sorry.
It's not a question. I just wanted to address our speakers, our panel. First of all, thanking everyone for
Yes.
being here. You know, it really is important that we get all the different perspectives and the fact that we have existing regulations that we have to work with. The existing framework is something that we have to consider. It's not easy for us to just change things, you know, the regulations. But again, thank you so much. And I just wanted to highlight the fact that I really appreciate Dr. Bushby being here, being a pioneer for HQ, HVSN. He has taught a lot of us who had been involved in this. And so I think his perspective, his recommendation is really worth looking into. So again, thank you so much, everyone.
Thank you. And now we'll open up to public comment. Any comments from the room?
Okay, Bonnie Lutz. Okay, I have a couple of comments. First of all, I don't know if a lot of you know this, but I was a microbiologist for 20 years. And when I was reading through this earlier, I mean, I totally agree with Dr. Bushby about the issues related to whether or not any surgery done in any vet hospital is sterile. Because in all the vet hospitals I've been in, I've always questioned that. So I do think that's an issue, and I'm glad it was brought up. As far as the high quality issue, that is a real, I'm looking at it from both sides of the coin. I'm looking at it from my clients who are going to have to determine whether or not they're doing high quality spays and neuters. I'm looking at it from the point of view of veterinarians who are going to want to jump on the bandwagon and just do this in their hospitals when they're not really doing these clinics. And I'm wondering if it couldn't be handled just with a standard of care issue, because basically standard of care is not defined any place in the Practice Act. And we deal with that on a daily basis. And what we have to deal with it, the way we deal with it is that we hire an expert who testifies as to the standard of care, because that person has expertise in that area. And I'm wondering if this quality issue couldn't be handled that way rather than defining what the quality is and or taking out the term quality, which seems to be an issue. As far as the volume, that's really an issue. I totally agree, because when you passed the new regulation for the small animal vaccine clinics, I had so many people, veterinarians, calling me saying, well, can I just do that in my office? And then I don't have to do the whole VCPR, and I don't have to do medical records. I don't have to do any of that. I was like, no, it's supposed to be a special vaccine clinic. So I do agree with the volume thing, the defining it. I just wonder if there isn't a way to specify it. And I know it gets so wordy, but to specify it with whether it's dogs or cats and a range maybe that's reasonable, where, you know, somebody couldn't actually hit that range in their hospital and try to fall under these exemptions. So anyway, I just wanted to put in my 2 cents. I think this is a very difficult issue, but I think it's important because these high volume, high quality, high volume spay and neuter clinics are vital for the whole system. So thank you.
Any other public comment in the room? Any public comment on WebEx?
This is the moderator. If anyone would like to make a public comment, you may look for the hand icon, typically at the bottom of your WebEx screen. Although if you are on a mobile device, that hand might be behind the 3-dot other options. And any call-in users can press *3 to raise their hand. Each speaker will have 3 minutes with a 15-second warning, and we ask people to speak only once per agenda item. And I do see that presenter Emily McCobb has her hand raised. Did you want to address her input first?
Just a really quick comment. If you do put a number, could you consider an exemption for training programs?
Thank you.
And so back to the WebEx attendees. Would anyone like to make a comment? I do not see any raised hands, so I'll turn the meeting back to you.
Okay. Can you hear?
Yeah, she has another comment.
Okay.
I also have an issue with the training issue because that puts it into another whole realm. And again, I can just see my clients getting in trouble or thinking they fall under that exemption when they don't really fall under it. So again, I'm looking at it from both perspectives, but I think that that's an issue.
And for those of you who don't know, Bonnie Lutz is an attorney. Okay, it is noon. Do you want to proceed on or do you want to take lunch?
I'd like to just make one comment for thought on this, is that I just wonder if we should be looking at this from because we started with this, a question of, is this something we should say instead of HQ, HVSN, or should we be looking at an exemption from a MASH perspective? So I just want to put that in our brains before we.
Yeah, that's for the next
Yes,
item.
exactly. I just
That's for
wanted,
5.
that's food for thought while we're eating food.
Okay. Yes, okay, so we're going to break for lunch and we thank our presenters. And so we'll take a 1-hour lunch and come back at 1 o'clock.
Thank you.
Thank you very much.
Thank you again.
Thank you.
Okay, we're back from lunch and ready to proceed to agenda item number 5, update discussion and possible action on minimum standards for alternate premises regulations. And Dr. Solicito and I were on a subcommittee, and Dr. Solicito is going to go ahead and proceed with 5A.
All right, good afternoon. What I will be presenting would be the HQ HVSN services and MASH clinic discussion under the subcommittee. For background, at the July 2025 board meeting, Animal Balance and the San Francisco SPCA submitted a letter requesting permission to operate mobile animal sterilization hospital clinics or MASH clinics throughout California. These clinics, designed to be accessible and affordable, can sterilize and vaccinate over 60 animals per day in temporary setups like community centers. The main issue is that current state regulations require permanent surgery suites, which MASH clinics do not provide. The board showed interest in further research and directed the MDC to examine safety data, infection rates, and regulatory changes needed for allowing these clinics. Meetings with stakeholders acknowledged that existing rules did not consider MASH-style practices, prompting continued review and discussion about updating requirements to support mobile, high-volume spay-neuter services. Now, the subcommittee researched this issue further, and the subcommittee independently researched HQ HVSN services and MASH clinics and spoke with multiple veterinarians with significant HQ HVSN experience. We also met with the UC Davis representatives responsible for creating the HQ HVSN education pursuant to Senate Bill 1233. With this, the subcommittee provides the following recommendations. First was the no amendments to VCPR requirement. Second, consider initiating a rulemaking to define high volume spay neuter services. B, provides specified exemptions for mobile veterinary premises from which services are solely provided at temporary pop-up locations created for the purposes of high volume spay and neuter events. And third, add notification requirements so the board can adequately enforce the minimum standards and so consumers know some surgeries may be performed as clean surgeries and not sterile surgeries. I just wanted to say that these recommendations were made before the earlier discussion, which, have brought different perspectives on this matter. Now, for the response to the VCPR concern, CCR Section 2032.15 states a veterinarian client-patient relationship, or VCPR, may continue when a designated veterinarian at the same location assumes responsibility for medical decisions and maintains knowledge of and continuity in the animal's care plan established with the original veterinarian. Any changes to the care plan must be promptly communicated to the client. Based on Animal Balance's presentation, they comply with this regulation. Despite challenges in MASH clinics, Animal Balance reported no concerns about the VCPR requirements, so the subcommittee does not recommend amendments. Now, the next item is defining high volume spay and neuter services. Again, this is before the discussion this morning. While high quality, high volume spay and neuter services is commonly used, it is not currently defined. Since high quality is subjective in nature and could imply standard spay and neuters are not of equal quality, the subcommittee recommends not including the term high quality in any definition. Using the term high quality may also mislead consumers into thinking the board has determined these services are higher quality based on set criteria. The subcommittee would like the MDC to consider high volume and spay and neuter services be defined as follows. A high volume spay and neuter service means the surgical sterilization by a veterinarian of 30 or more dogs, cats, or rabbits, or any combination thereof within 12 consecutive hours. Next, the specified exemptions for mobile veterinary premises. CCR Section 2030.2 defines a mobile veterinary premises as a vehicle or unit from which veterinary care is delivered. Large animal veterinarians and those making house calls use their vehicles with portable equipment and medications to visit barns, stables, fields, or homes. If not attached to a fixed location, these veterinarians register their mobile unit with the board instead of each site visited. Mobile veterinary premises must meet all minimum CCR 2030 standards, except for signage 2030A5 and building codes 2030E. CCR 2030.2A ensures consumer protection, and the exemption clarifies that temporary locations like barns or homes are not subject to veterinary building codes. Next item, potential exemption for a septic surgical room. The current request is to exempt HQ HVSN services in MASH-style clinics from needing separate surgical rooms, allowing procedures in designated open areas. The subcommittee reviewed whether high-volume spay-neuter surgeries require aseptic or clean conditions under CCR 2030D. Aseptic surgery involves practices to eliminate microorganisms and is typically required to be performed in a separate room per CCR 2030.2C. In contrast, clean surgery is defined as operations where aseptic technique is not warranted. Instruments must be sterilized and personnel wear clean clothing, but no separate room is needed. Field surgeries on equine and livestock are generally considered clean and do not require separate surgical rooms. This is primarily due to practical limitations such as environmental challenges, contamination rates, field limitations, and cost. The goal of a clean surgery is not to eliminate all bacteria, but to reduce the number of germs to a level that the patient's immune system can handle. I'm trying to kind of like to summarize the memo because it can be a very long day. Okay, so traditional versus high volume. Small animal spay and neuter surgeries were traditionally aseptic, but newer high volume methods use smaller, precise incisions and are much faster, less than 15 minutes before versus 30 to 40 minutes. Although data is limited, entities performing high volume techniques report low infection rates. This has led to the debate whether these procedures qualify as clean surgeries. High volume space versus high volume neuters. The subcommittee and board staff, in consultation with the UC Davis veterinarians developing HQ HVSN education per SB 1233, agreed that space for cats, dogs, and rabbits are aseptic surgeries. In contrast, feline neuters and scrotal canine neuters are considered clean surgeries, as they involve healthy tissues with minimal contamination risk and do not require full aseptic conditions. For the separate surgical room, consensus exists on clean and aseptic surgeries, but opinions differ on whether high-volume space in MASH-style clinics must be performed in a separate surgical room. Some argue that only a dedicated surgical room ensures asepsis, citing risks like hair contamination during surgical prep. They suggest surgical tents can fulfill this requirement. Others believe that using a distinct area located a specific distance from a source of contamination is sufficient for maintaining aseptic conditions. Allowing space to be performed in a designated area aligns with the ASV 2016 Veterinary Medical Care Guidelines for Spay-Neuter Programs, which was provided together with the memo. Now, operating area environment. The operating area should be a room or space in which anesthesia, surgery, and immediate post-operative recovery can be safely performed. The necessary equipment for performing anesthesia and patient monitoring should be present and readily available. Traffic within the operating area should be limited to essential personnel. Sanitation procedures should be carried out on a regular schedule. Since a consensus was not reached, the UC Davis representatives and other surgeons specializing in high volume space and neuters were invited today to present their perspectives. The subcommittee requests the MDC and the board to discuss all perspectives and consider the consumer and patient impacts of the requirements. If entities such as Animal Balance claim they cannot comply with a separate surgical room requirement, the risks to animal patients if aseptic space are performed in designated areas should be compared to the high animal euthanasia rates throughout California. Additional exemptions. Similar to animal vaccination veterinary premises, high-volume spay and neuter mobile veterinary premises are solely providing specific limited services at scheduled events. As such, the subcommittee recommends considering exempting mobile veterinary premises performing services at the high-volume spay and neuter events from the following. Unless otherwise specified, all veterinary premises under CCR Section 2030A shall maintain the following standards. The veterinary premises shall have the capacity to render diagnostic radiological services either on the premises or through another veterinary premises or outside service. Radiological procedures shall be conducted in accordance with all applicable state, federal, and local laws and regulations. Clinical pathology and histopathology diagnostic laboratory services shall be available within the veterinary premises or through another veterinary premise or outside service. And sanitary methods for disposal of deceased animals shall be provided and maintained. In addition, the subcommittee recommends considering exempting mobile veterinary premises who solely provide high-volume spay-neuter services at low cost or no cost to the public from veterinary premises application, registration, and renewal fees. Low cost could mean a certain percentage, maybe 50%, or lower than the average price for the same services within a certain distance, example, within a 50-mile radius from the event location. Since fees are set in statute, this exemption would likely require legislation. So board notification: to ensure these high-volume spay-neuter events comply with required standards, the board would need to be notified ahead of time when and where the events are occurring, as well as what veterinarians are performing the veterinary services. If fee exemptions are requested, the board would need to know the method for determining whether the services were low cost. Consumer notification: to ensure consumers are informed prior to having their animals spayed or neutered at the high volume spay and neuter events. The mobile veterinary premises should notify consumers that some surgeries may be performed as clean surgeries and not sterile surgeries. The requested action by the subcommittee, after thoroughly considering all perspectives, to please provide further guidance on the subcommittee's recommendations and what should be included in draft regulatory language.
Thank you. So there's more than one issue here. How about if we just take them one at a time? So the first one of the VCPR language saying that we don't need any amendments. Any comments on that? There's no amendments needed to the VCPR language. We're all okay with that? Okay. Definition of HVSN. So we came up with a definition of 30 or more surgeries within 12 hours of dogs, cats, or rabbits, any combination.
The proposed language is 30 per veterinarian.
Per veterinarian, 30 per veterinarian per day.
So
for 12 hours.
this is where training can come into play. So I believe maybe because we have to define a number, maybe focusing not on how many that veterinarian can do, but the output of the clinic at the end of a 12-hour day should be the limit. Because if you have, let's say you have a new grad that's learned this technique, and if it's written down that in order for you to be a high volume, high quality at this event, you have to put out 30 a day, that's a training issue because he or she may not. And if it's written down like that, then they might be concerned that if someone were to complain, well, she got to do 15 spays, even though there's people training her there, and she's already a licensed DVM at this event, that got an exemption. So I think focusing on 30 or more of the clinic output instead of putting the onus on per veterinarian might be a discussion, especially even the higher. I know when I was a student on these, when I opened up and it was a pregnant Rottie, they immediately have you step away, right? And they scrub an experienced vet in, right? So right there, that's taking one away from me, technically, if we're doing 30 per vet, right? And again, so this is also a training issue too. How are we going to train them in a high quality, high volume environment if we're focusing on a minimum per vet versus per clinic output?
Christy.
I understand what you're saying. However, what if one hospital has 5 veterinarians and one has 1? So
that's the
you
problem.
can't, I get it. There's no, but what if that scenario doesn't work?
But that one veterinarian, if they're training and they can't do 30, they're not doing it.
I don't agree with the 30 number, but I'm still saying you can't put a number on a clinic when a clinic doesn't have the same number of veterinarians. So the same clinics don't have the same number of veterinarians.
Correct, but in order for that clinic to put out a high volume, that clinic has to have a minimum, it has to have the intent to spay or neuter X amount of, and if it's one vet that can't do that, right? Like, let's say my RBTs don't show up, 2 vets don't show up, and this one vet can't do 30,
Then they shouldn't be doing it.
correct?
So we're talking about events here, remember? This is not, yes. Dr.
Pop-up
Sullivan.
events, right? Like, let's say I was the only vet that showed up and I'm like, oh, I don't know if I can put out, well,
But if they are classifying themselves as at this classification, then they shouldn't be doing the training there. They should be getting the training before they get there. So if they're doing this event, they should already have the training and be living up to that standard.
I actually disagree because there's a lot of students that do the training on this because private clinics are not going to be like, can I come to your clinic and do this? Now, even the training, right? That doesn't mean that in a formal, high volume, high quality, you're not doing 30 of these, right? They might teach you the technique, just like vet school. How many spays did you do before you were licensed to become, a vet? Now it's like, okay, well, in order for you to be at this event, you have to do you have to output 30. And it's like, well, I'm still training here. So my fear is this: if we assign it per veterinarian, the majority, I'm going to guess that the majority of licensed veterinarians that are interested in this, students coming out of Davis and stuff, we're putting a high, I would say we're putting a high expectation of that on them. Now, if I'm a new vet doing this and I've gone through the training, but I'm like, this is my first MASH clinic, right? There's other veterinarians there. So training for that is even the first one you do, and it's like, you're going to sign up for this, great. You have to do 30, right? Now, 7 of those pitties happen to bleed out. That's the thing, is actually putting in number how many a vet has to do is not going to take into effect complications. And if we're worried about the quality and stuff, if I'm just worried about hitting a number myself, maybe I am going to cut corners, or maybe that dog might
Dr.
not be post-op.
Doctor, I just don't want to interrupt you, but Dr. Brown and Dr. Bushby both said 20. They both said 20, and they said students participate in that. That is a student number, that is a training number, and they both said 20. And they agreed that that was a good number. So, and they included trainees and new students in that.
So students wouldn't be under this because they're not licensed veterinarians.
New grads and people right out, we're talking
So
about trainees.
inexperienced veterinarians at this, not inexperienced, but
But you're saying trainees and people who are coming in training, and you're saying newly licensed veterinarians.
yeah.
So you included that in this, and so that's.
Okay,
what
I'll
they-
take the students out because they're not licensed
Right.
veterinarians.
So
that would be to me, if we worked at the same clinic and I'm a new grad, even though, yes, I did learn how to spay and I might have done 2 at Davis. If there was an expectation of me to do 10 spays on my first day, even though I'm trained, as much as I just want to take into effect there that if they're like, you have to do 10 dog spays a day starting now because you're a vet, because that's what everyone else does, that's going to make me double think like, whoa, hold on. I want to do this technique. I want to do it right. So I'm a little, that's just my concern, is, are we going to hinder veterinarians from participating if we are assigning?
maybe then that's what they're saying is,
Right.
this is the definition when we have to look at this.
Okay,
right?
Dr. Sullivan.
So in that situation, that person should be already working in a shelter, getting the experience to get up to that quality. We're doing an exemption for a group of veterinarians that have a skill set that isn't just from coming out of school. So if you need that skill set, you go to a place where you can get it, but it's not a training facility.
This is an event, not a facility.
Right. But the veterinarians that are participating in that event,
But normally,
Training, they're going to, if you're.
well, training
if
meaning
you're-
I'm not as experienced as you.
If you're at a MASH event and you're new and there's other veterinarians there, they're going to give you the cats and the puppies.
I think-
Kathy.
I'm sorry. Can I just say, for events like that, usually even if you have under-experienced spay and neuter veterinarians, they always have to work with an experienced one, right? So
Correct.
technically, if the person is more of like support, that is not being considered as their training. It's just giving them experience. So the exemption is now going to fall on the primary veterinarian who's running the event. So I would say they are not going to be evaluated as, hey, you're not in compliance because you're not a high quality, high volume spay neuter. The exemption would be establishing that there is a veterinarian qualified to do this, and that is the bare minimum.
So if I did 19, let's just say,
Mhm.
like, for whatever reason, we're down two vets.
And you're not by yourself. You have
No,
somebody.
there's two of us, but we're down two RVTs, so now anesthesia's slow, the day up, right?
Mhm.
And then I've got, for some reason I did 19. And this is very by the book because on the other side, once it's written down, if someone does file a complaint saying, well, why did they get to be high quality, high volume? She only did 19 and it's written that to qualify that one that has to do, like, I just want to think about after putting down a hard number, what could be, and I know we have to, but do we have to on the output of every veterinarian that's there? Or do we have to on the output of the event? Like the event has to qualify, this event has to do a minimum output of 30.
Okay,
Now,
Kathy's next.
yeah.
I agree, this is kind of a tricky discussion to create this definition. I first thought, well, maybe you just do it per day, how many are done, but that's right. We don't know how many vets will be on call. So you say 80 or 90 a day, they say they can do 200 in a weekend. That's with a full complement of vets. I do think it has to be per vet per day. If it's 20, whatever, I leave that to you guys. But I will say that we are dealing with organizations that are professional at doing this. These aren't just me coming in and say, I'm going to put a high quality spay neuter clinic on. And I assume they know the individuals that are participating, they're professionals. They knew who they've got signed up to be patients, et cetera, et cetera. So I think it would be one thing if this was a kind of a willy-nilly operation. And I assume it will not be, that these are going to be professional organizations.
Dr. Nunez.
I have a point that might strengthen your argument. Because it sounds like we're considering these MASH events as a mobile practice. So it's an exemption to the premise permit that we're talking about. And so if it's an exemption to the premise permit, then it should be the number of procedures the event is doing per day. One of the presenters did ask for an exemption for training purposes. So maybe there should be an exemption to the exemption, that if you do have more trainers on that might not be able to do 30 per day, then that could take care of the concerns that you don't have enough qualified people to reach that number. But I do think since it's an exemption to the premise permit, it should be more related to the numbers that the event does per day, rather than the veterinarian.
I just want to make clarification. We're not asking for an exemption to the premises registration itself. It's the exemption to requiring that the aseptic surgeries be done in this aseptic surgical room is a specific exemption. So you still have mobile premises. Some of them have to be registered, some not, depending on if they're tied to a fixed facility. But they would still, if they.
When they operate and apply for it, when they apply for a license, they apply for a mobile permit.
So I think that's up for discussion of how it would be implemented based on how it is written, but they could fit under the definition of a mobile veterinary premises, which is where the direction of the subcommittee was going. So they would still get a mobile veterinary premises registration.
Yeah.
It's just currently under the regulation, if you have a mobile veterinary premises registration and you're providing aseptic surgeries, you still have to do those aseptic surgeries in a separate surgical room. This is asking for the exemption to that.
Yes.
Not the exemption to the overall premises registration.
Right.
Point of order.
No, okay.
I have a point of order. Jessica, could you kind of frame this within the legislation that is being proposed and heard this year? Does this work, will this work apply to that statute, or does that take, if that statute passes, does it take everything out of our hands?
Yes and no. So you have AB 2010 that's the bill is being referred to. And right now it has language for high quality, high volume space and neuter services. It has a definition for that, which aligns with the 20. That is what they're asking for is a 20. But the way it's currently worded, I think there's overall concerns about how it's worded, but the intent is to exempt them from that separate surgical room. And so if the legislation passes as is, then the regulation for here would not matter. That legislation would essentially trump the regulation itself, but any other standards that aren't specifically prohibited in the statute would still then apply. So, yeah. I don't want to get too far off because that's not on the agenda, but that was what would happen.
Are we going back and forth between 20 and 30?
As far as number of surgeries?
Yeah,
Well, that's
because
still up for discussion. Kathy? No. Okay, Dr. Sullivan? You're just waving your hand.
I guess I just wanted to point out that if you are going to be declaring your facility to be high quality, high volume, and you're seeking exemptions, then I would say operations should not be relied on trainees, right? You have to be able to establish that there is somebody qualified to do the whatever number 20 or 30 that we decide on.
Yeah, I agree. Should we talk about the number more? 20, so 30?
I guess the experts have spoken earlier. 20 is a reasonable number.
I have a comment.
It's just a minimum. It's not the, you know,
it's 25.
total.
25.
I could go with that,
25.
25.
Middle ground.
Okay, are we going with 25 then?
Can I ask what's wrong with 20? Like, why did we go to 25? Like, are we just arbitrarily pulling numbers out?
We asked veterinarians when we talked to them about how many surgeries were being done, and it seemed like 30 was a minimum number. So it surprised me that they said 20 today.
I would say the 30 came from, you know, something, and I'm speaking from experience, something about high quality, high volume. Sometimes you have that bragging rights of how many you can finish in a day. And I tell you at the shelter, that's a regular thing. And so 30 is like, I can do this. You know, that's my badge of honor. But realistically, I would say considering staffing, considering the number and types of animals that you're going to do, 20, I believe, is a reasonable number.
Dr. Sullivan?
So if I remember correctly with Animal Balance, they screen their surgeries. So they're not taking in 80, 90-pound older dogs. They're taking those in that they can move through in that rate. So again, we're not talking about a subset. We're talking about those people that are doing this seriously, going in and doing a community service and doing the numbers. And so I think there's got to be a higher level there as a base than just an average.
And I just wanted to say that is also a problem when the types of animals are being regulated, because now in LA County, there is a huge amount of dogs over 50 pounds that are not being altered because they're being refused. So that's why I'm saying if we make the number a little realistic, try to accommodate, you know, so that they would be more open to like even doing a lower number, but taking care of these big dogs.
I move we go with 20.
I just have a question to the vets here, since this is, again, an exemption for the high volume, high quality. Could a veterinarian provide, do 20 in a day in their own vet hospital?
But it wouldn't be an event.
So somehow the definition of what this is will preclude a veterinarian in practice in a premises from being able to qualify?
I think it would be challenging for
So,
veterinarian in a regular setup to do 20.
so I don't want to confuse with existing registered veterinary premises at a fixed facility, because they do all sorts of aseptic surgeries, not just specific to high quality, high volume spays and neuters. And so if they want to do a high quality, high volume spay and neuter service or event, they can do that in their clinic, and their clinic is already complying with the fixed facility premises registration
In their
requirements.
surgery room. Yeah.
Yeah.
Okay, well, there was a motion, but I was going to go ahead and,
No, there's no,
he said I move. No, I know there was no second, but, so we're, okay. So are we at 20 then?
I'm fine with 20.
Well, I was going to go on and then make a motion for the whole thing.
What have we talked about? High quality?
Well, that's like next on the list. I just want to make sure if we're okay with 20. Want to go 25?
22.
Okay, yeah. Okay, the need for aseptic surgery. So we've come to a definition where we all agree that spays need to be aseptic. It's the definition on how that is done. As far as needing a separate area for surgery.
wait, I'm just going to ask before we move from that, if we can talk about the high quality piece of that, because first is defining what we're talking about, and then we can move to where they can be performed. So I just wanted to clarify some of the statements that were made before about not including quality in the definition. If you don't provide a definition of what high quality is, that's where it becomes very subjective. And yes, we absolutely can fight in every single case standard of care. But speaking from a board who then has to pay for the resources and battling the experts out for standard of care, I'd rather have an easier way to say what quality means. And from the presenters, they were talked about, well, it's quality because they follow these standards. If you want to require that they follow those current standards, you can reference the current ASV standards that quality, so you could put into the definition that they follow those guidelines. So if they don't, then we have something the easier to enforce, rather than every single case be a battle of the experts for standard of care. So you could put that in there, but if you don't have something that's more objective as far as what is quality, then it becomes very challenging from an enforcement side to enforce it.
Question. So if we decide to call it a high volume spay neuter, that doesn't preclude them from them calling it.
Sure.
They can call it whatever they want.
Yes.
Dr. Nunez.
I would almost agree that it is high quality, because we don't have any definition in our Practice Act of how a veterinarian should be performing a spay or neuter, because we don't define how you should do surgery. I don't have a copy of their guidelines, but it sounds like their guidelines do
You do. They're in the packet.
clearly define AR. They have procedures on how the clinics should be set up. So they're a lot more descriptive than our Practice Act is.
But our Practice Act didn't even have a definition of
Yeah.
surgery.
But I don't think they were catastrophizing it, saying that if you take out that term, high quality, it'll be disastrous for our community, similar to the shelter community saying that removing owner exemption is going to be disastrous for them, but that's another point. However, I do think that it could affect fundraising. If that term high quality could help with fundraising, and these programs do rely on fundraising to make.
But they can still call it whatever they want.
But this point you just made, that they can call it whatever they want, just in regulation, if we can get away with that, that'd be great.
Dr. Sullivan.
I I think if we don't call it use the same acronym, it's going to be difficult. I like linking it to a standard that we can apply. That to me takes care of my concerns. I didn't think we could, but if we can do that, I'm fine with that. Then we have something we can go back to. This is what you're calling yourself, just like a person who implies they're a specialist. Now they're held to a higher standard, whether they are or not. If we define this and people say this is what they're doing, now we have a standard that they can be held to.
Could we call it
Christie.
the
Your hand was up first.
Yeah, I absolutely agree because I like that it then, yes, there's a lot of reading and I understand that that's difficult, but it is a standard that we can link to, and I appreciate that. And I like that they're actually updating them now and they have a task force. So I believe it gives more backing to it. And so it will be updated even in 2026. So I like that it would be HQHVSN. So.
Dr. Solcito.
I agree as well, because I feel like having the term high quality not only upholds people to a higher standard, it would also eliminate all those who would just jump on the bandwagon and try to use that for the exemptions or whatever benefits that they would get out of this. So to be held to standards, just as defined by the ASB guidelines, I think is important to be placed in the name.
Kathy.
I've gone back and forth on this. At first, I agree with the subcommittee, and then I listened to what they said, and I understand. But what generally bothers me is how come this is going to be called high quality, and there's no other high quality in the rest of the veterinary profession. So it seems like this, I don't know, it's just a weird difference, right?
Just
So-
to follow up, just like what Dr. Waterhouse had expressed before, her concern with her own experience with people who's been doing all this space and neuters, but then there are a lot of complications, and maybe because they are not held to the standard that is being promoted by now this group of experts who's defining why we are calling it high quality, because there are certain specific things that they need to, adhere to.
And I forgot, during their presentation, they also realized that this language, this HQ, high quality, high volume, has been around for 20 some years, it sounds like, and the nomenclature seems to be out there. So I do understand that.
Dr. Nunez.
I don't know what the acronym would be, but can we call it the ASV Veterinary Medical Care Guideline Approved High Volume Clinics? Because that would let them know that there are guidelines that they must meet.
We'll just put it in the definition.
ASV approved, ASV guideline approved.
It would be linked to those standards.
Yeah.
You don't have to have it in the wording, but in the regs, it would be linked to that.
So include that in the definition. It would be ASVVMCGHV.
We can work on the language.
Yeah, that's.
But there are inherent challenges when you are referencing actual guidelines themselves too. So I just want to make sure that that's well discussed as well, because you have with everything with the profession, it's ever evolving. And so you have the set guidelines and they haven't changed them since 2016. And so just keep in mind that that's going to be, and so I don't recommend ever doing an actual date, because if they update them, you want them to be the current guidelines. So whatever is currently out there. But also keep in mind that if you do that, you're referencing the entire, all of the guidelines. So, I mean, maybe, but if that's the direction you want to go in, maybe that's the feedback to provide the board.
That we have to review the.
We would have to review that to see if is that really what we want, or is there a section of that you want, but you just have to be careful of what we're asking for, because you don't want to make it more challenging than what it should be. But it could be just a consensus, if we get a consensus from the MDC to provide that feedback to the board and say, we would like to potentially tie high quality to the standards that are published. then that could be the direction. And then we continue to look at the actual, all of them to see, is this really what we want? And also for clarification, the MDC doesn't have to do any actual motions. There's no action that's necessary. It's just if we can get some consensus on these topics and provide input to the board for the board to decide what they want to do and where the direction they want to go, then we can take that, go back and work on the language based on the feedback from the board. So there's no formal motions that we need. We just need consensus on the topics to provide to the board.
I mean, there is one section that says operating area environment.
Right, that's in the memo as well. So what from, just making sure I'm understanding and to try to keep this going, it sounds like so far the consensus is 20, and the consensus sounds like that you all want to keep quality in there, but tie it to the idea of the current published standards that are in the packet. Are we on? Okay, now we can move on to separate surgical room versus separate surgical area.
And I don't think that that's in their guidelines.
It does. So there's in the memo too, it also has the specific paragraph, but it actually says area or room. And so when I was talking to Dr. McCobb about that, she acknowledged that that could be something that's tightened up a bit too, about talking about the foot traffic. And I said, what if you have, I think picturing a gymnasium, and you don't want to have that surgical table that they're on right next to a garbage can, right? So think about things that you would want if we're okay with an area, because the guidelines allow for a separate area. So if you're there, what are the things you want to consider? Or is it the consensus that, no, it has to be done in a room? But to your point, Dr. Nunes, it is in the guidelines that allows an area.
So our subcommittee, Dr. Solicito and I have a different opinion. I'm pretty adamant that it should be a separate surgery area. It doesn't have to be solid walls. I'm for the tent. And if they're concerned about heat building up in the tent, they just need a bigger tent. I look at our current minimum standards for this mobile practice, they have to have a separate surgery room. So obviously it's a mobile, it can't be that big. So you can get a tent bigger than that. And I also am in my own surgery, in my own hospital. I have a treatment room that's about 25 foot wide by about 55 foot long. Has 7 tables in it for animals to be worked on. At one end, the table furthest on the one end is the surgery prep, because it's right next to the surgery room. And in this long, narrow room, I have 5 air vents. I have 5 furnace filters or HVAC filters that need to get changed monthly because every veterinary hospital fights hair. There's so much hair. So I went to our guy who does maintenance and cleaning and asked him which furnace filter builds up the most hair. Guess which one?
Surgery.
It was not the one over the prep table. It was the one clear on the other end of the room. I stepped it off. It was 40 foot away. So 10 foot's not going to do it. I was surprised too. It all moves around. It's air currents. And I just hate the thought, this requirement for sterile surgery instruments, as soon as they open up their surgery pack and they're in this open area, that hair is going to be falling down on your surgery instruments. To Dr. Miller's point, I'd rather do this outside than do it in that room with all the hair, as long as you could assure me there were no birds flying over.
And as Dr. Waterhouse said, like we were on opposite sides about this requirement. And all I could say is that I defer to the experts who've done this setups, and can have data to support the fact that it's not it's a non-issue at all. Because again, there is that expertise behind it about like how quick, how small incisions are, and how, the tissue handling is. Again, it comes with that expertise. So I would say, yes, the requirements are there, considering what is happening in that, what you call this, in a specific practice. And that is a valid concern that, in Dr. Harv's experience about having evidence of, hair traveling as far as 40 feet. But I would really just wanted to say, if that is a true, and I don't know how long that took for that hair to
A month,
travel, like just a month.
change it monthly.
Yeah. Yeah. So, but the thing is, the setup, the equipment and everything that's in the facility is totally different from how these MASH type clinics are being set up. Again, I would like to defer to the data that is being provided to us by those that have done thousands of animals benefiting from that layout.
Christy, oh, sorry. Dr. Good.
I will say, on the flip side of your hospital, there are a lot of fixed veterinary premises that inspectors are trained when you go into surgery. Everything is beautiful and stuff. The number one place that we do this is the top of the surgical lamp that gets moved all the time. There's hair and dust there because a lot of people don't realize that's part of the cleaning protocol. So on the flip side, the most beautiful, immaculate looking, surgical suite the potential for hair contamination there. When you move that lamp, like I said, it's the number one violation. So just because it's a fixed premises and, doesn't mean it's going to have 7 air filters and stuff like that. So I just want to make it clear that just because you have a separate surgical suite doesn't necessarily mean you're doing everything possible to keep that space aseptic.
Christy, did you have?
Yeah, so my thoughts are, I've gone back and forth on this, but then I had a nice conversation with a boarded surgeon, and I understand the 4 walls. They're important, and I think they're important for the standalones, and they provide for the premises, the normal everyday practice, and I think they're important. However, we're looking at this for a different purpose, and we have animals being euthanized at just an outrageous number, and we need to look at this for a different purpose. And they're providing services that our everyday hospitals cannot provide, and they are doing it at the rate of the surgery, the speed of surgery. And this is what I talked to the boarded surgeon about: the speed of surgery, the amount of anesthesia time, and the incision, the size of the things that Dr. Bushby talked about. We're not comparing apples to apples. And their data that Dr. Solicito spoke about is proof. And then we compare that to the number of animals that are being euthanized. And so we need to have an exception. We need to make this exception. So yes, a spay is an aseptic surgery, and we need to look at what is the distance that we need. I don't think we need the 4 walls. Okay, I think that needs to go away, and we need to just look at what is the appropriate distance and what are the requirements that we need to make. No garbage cans. There needs to limit foot traffic. We need to make sure people are wearing proper PPE, and those are the things that we need to have in the requirements, and that's what we need to be looking at. That's my opinion, but.
Dr. Sullivan.
Yeah, the problem that I have, and I don't care how it's set up, they're going to run into complications at times. So If they're screening for these low-risk patients, that's okay. But if they're not, if they're getting into a community that has larger animals, older animals that need to be spayed, now all of a sudden, we're outside these parameters. How are we going to address that? Because the cross-section of spays and neuter, well, spays of dogs coming into our clinic varied tremendously. And we didn't screen them. You can't screen them in a practice. So if they can screen them, I think we're okay. But if they're not screening for the higher risk patients, then I don't think they're addressing the needs of all the communities that they're going to. So I have some concerns about doing this on animals that are not fitting their protocol.
And we have to remember that these are owned animals. I agree with you totally about the number of euthanasias. It's a huge problem. It's, if we were just talking about animal balance or a group going into a shelter and doing all their animals that are not owned, I'm fine. I don't care how they do them. They can go in there and do them whatever. And if you got a 1% fatality rate, you may look at that, that's okay, considering the balance we're trying to reach here. But we're talking about animals that have owners here. And we're a consumer protection board. Well, we're the committee, not the board.
But they're still being euthanized because or something's happening to them because they're not getting spayed and neutered.
Dr. Sullivan.
So I think that there's more work that needs to be done on this by the subcommittee. I think one thing that we need to address is by looking at, let's take animal balance, they're the ones that were here, and let's look at their criteria. And let's see if because I haven't read it, as if there is a weight requirement, an age requirement. And let's see.
They said there was, but I don't recall.
Well, let's see what it is though. And does that mean that all of these practices are going to fall into that prerequisites? Because the whole idea shifts if you're going with larger and older animals, then this, 7 minutes or 10 minutes or 15 minutes isn't going to follow in all those animals.
Right. And we're not just talking animal balance either. Aren't there other groups?
Yep,
Yeah.
the
So it's
presentation
not
does.
just animal balance. Kathy.
This is so interesting. Yeah, I think what worries me about a pre-cleared group of dogs and cats coming in, it kind of seems to me to defeat the purpose of what these high volume clinics are supposed to be, available to people that can't afford it, and that they may have all different dogs. The problem is, as we have said, is then you run the gamut of different types of surgeries, different complexities and things like that. But if we limit this exemption to folks that are screening for smaller, younger animals, I think that sort of defeats the purpose of what these things are supposed to be doing. Does, regardless of the discussion of in-room, in four walls, does changing these high volume surgical centers to clean surgeries versus aseptic assist in any way here? I know there were some problems with that and they had some concerns about it, but does that change the needs for the surgical facility?
The guidelines say it
As
should.
it's in the guidelines.
The guidelines say that all space should be aseptic.
Oh, their own guidelines.
Their own guidelines.
Oh, okay. That's their definition. But our definition of clean surgeries in a rural or large animal could be outside, right? Or in a barn or.
I boldly propose that we accept the operation area environment as defined in the memo. Yes, it clearly excludes the four walls and the door, which may increase the risk of contamination, but that is offset by the speed of the surgery, the size of the incision, and the skill of the staff performing the procedure. I disagree with the no trash cans that Christy had said, because this policy does say sanitation procedures should be carried out on a regular schedule. So maybe take the trash with you with every procedure, not necessarily no trash cans, because that's to be a can to throw the blood-soaked gauze in. And the only thing that I might add to this is the distance from surgical prep. You said your vent that was 40 feet away from surgical prep had the most air. So maybe 60 feet. That was my bold proposal. So
I know, I wish my treatment room was bigger to see if there was a better area. Dr. Gedkin, did you have a statement?
Yeah, as far as these being owned animals, yes, they are. But ultimately, this is a procedure that the owner is asking for, and the veterinarian thinks that they have the skills and the patient is a good candidate for this procedure. So the screening, not screening, I get a little worried about that. I don't want to be dictating, well, they should do, they have to be younger or something like that. If maybe this 9-year-old Pitties had, they're worried because there's a lump or something like that. No one's going to operate. I'm worried about putting them under anesthesia, or it's $1,000. Am I more worried about the future health of that pet or hair? Because ultimately it's coming down to that. This is the clientele, is they're not going to the private hospitals, right? So there's always something at risk, and we just have to do the risk benefit of how worried are we about hair contamination, right? Versus declining this or putting an extra, maybe a burden or an extra step that we're not sure would change the data on a service that might be conserving money to actually put, we have to keep in mind who we're serving. And like I said, ultimately it is the client, and it is on the knowledge and the expertise of that veterinarian to move forward.
Spectrum of care, gold standard, minimum standard.
I agree. And so what we're going to do is a straw poll. It's not a vote. We're just doing a straw poll of separate surgery room provided by a tent or some structure, or no, just taped off surgery area.
Okay, what's yes and what's no?
So
If we call your name, just say room or area, okay? And this is, again, not a vote, it's just so, because we're not going to get a consensus here. We need to know where we're standing, and then I do think we should do public comment, but Christy,
Area.
Dr. Solacito,
Area.
yeah? Area. Dr. Sullivan.
Yeah.
Dr. Waterhouse,
room.
Dr. Getkin,
Area.
Dr. Nunez.
area.
Area.
All right, thank you. Okay, so you can talk about, if you want, you can do the rest of the memo. You can open up to public comment. What do you want to do?
Let's do public comment. Public comment in the room.
Hi, Grant Miller, Regulatory Director, California Veterinary Medical Association. I'd like to make a public comment in regards to the earliest phase of the conversation regarding the VCPR and your conclusion and recommendation that it not need to be altered. I'm respectfully going to be pressing the board on that possibly in the future again, because the CVMA does have a task force to look at that very issue of the VCPR in these HQ HVSN environments. And while we have directly observed animal balance as well and found that they can potentially comply with it, we're concerned about many of the HQ HVSN operations in which there are not multiple veterinarians, and there are several that only have one veterinarian. And in our task force discussion most recently, which Dr. Solacito was present as a liaison to your board, it was mentioned by several of the doctors there that they have been volunteering at events in which they are really trying to focus on just doing the surgery itself. And so I think that that topic of the VCPR and whether or not it's being actually achieved in accordance with 4826.6, I do think that will need some future discussion. And so I'd just like to respectfully request that you keep an open mind to that because we will probably be returning as we make more progress with our own task force. Thank you.
I have a couple of comments. First of all, I had a question on the VCPR as well. And one of my questions was whether or not, because I get a lot of clients where the complaint is that they didn't discuss the treatment with the client. And so I doubt seriously whether these high quality, high volume spay and neuter clinics are able to adequately cover the VCPR the way it's written in the Practice Act currently. So I do think that that has to be looked at, because I would hate to see these people get in trouble just because somebody complains and then they say, well, you didn't have the adequate conversation with the client about what was happening. And I can see that happening. The other issue I have as far as the high volume and the number, I'm not going to get into that, but you keep calling it an event. And I'm very concerned about that term. Is that, I mean, from what I've heard, it's not going to be defined as an event. And what exactly is an event? Because somebody said the issue is whether willy-nilly vets will want to do this. And I think that that's the issue again, is that I'm going to get the call as to whether can I do this in my practice and not have to do X, Y, and Z and still comply with this law. So I'm really concerned about how you're going to define an event and how you're going to make sure that that is actually an event and not something that's ongoing. As far as the quality, I do like the idea of referencing a standard that somebody can read. I'm a lawyer, so I like things like that. So I think that's a great idea. As far as the separate surgery, again, I was really pleased to hear Dr. Bushby kind of clarify that, you know, for most of you, you're not providing surgery in sterile environments anyway in your vet hospitals. I'm sorry to say that, but it's just the reality. And it's based on my being a microbiologist for 20 years and all this throwing around about aseptic surgery. I mean, you do the best you can, but if the data is there that when they put on these clinics, they don't have huge contamination rates, then I think we need to really look at that. Thank you.
Okay, so we talk about the exemptions, the building standard exemptions.
Yeah, the rest.
Okay. Okay, so the rest of the memo is talking about the building standard, I'm sorry. Oh, sorry, public comment on WebEx.
Thank you. This is the moderator. If anyone would like to make a comment, you can look for the hand icon, typically at the bottom of your WebEx screen, or if you're on a mobile device, it might be behind the 3-dot other options. And we don't have any call-in users, but we do ask people to speak for a maximum of 3 minutes. We'll give you a 15-second warning. And please don't ask to speak more than once per agenda item. Are there any comments on the discussion? I do not see any requests. I'll turn the meeting back to you.
Thank you. Okay, so we also need to talk about the building standard exemptions, you know, such as no need for radiology, no need for histopath or lab. Besides the things that we mentioned in there, is there anything else? Everybody's good with Kathy?
I don't know, and maybe Maria knows or others. What do these MASH clinics do if an animal passes away with the animal?
Usually when events like this are planned, they already have identified like local veterinarians that they could work with, emergency hospitals that they could send to. A lot of times they're prearranged kind of, you know, that we're having this event, notification basically, we're having this event in this area on this date, blah, blah, blah. And then, you know, if anything happens, then they transfer immediately.
And it's not up to the owner to do that. They have arrangement with the emergency vet to come and get the.
They usually, if
consumer
it's
done.
an emergency, it's immediately transferred, but of course, the
Okay.
clients, if, because usually these animals are dropped off, you know,
I know.
they
and
would
they're-
have signed off on a consent prior.
That's right. I forget.
Yeah.
Okay.
Okay, any other comments? Move on to,
So you have,
oh, okay.
the board notification and the consumer notification. Do you want me to?
Okay.
do you want me to-
Yeah, why don't you go ahead?
Okay, so a few other things just left in the memo, just to kind of get a consensus from the group to see if you like those. One of the discussions was potentially looking at exempting the mobile veterinary premises who are providing these services, whatever that term that we come up with. If they're providing low cost or no cost to the public, then potentially exempting them from the registration, application, renewal fees, if everybody is on board with that. Okay. The other thing was about looking at doing language for a board notification. So the idea is to make this as least burdensome as possible. And I was talking to Dr. McCobb about how potentially to do that, because these are obviously mobile, but they are 1 to 3 day long events. And I know Bonnie doesn't like that term, but 1 to 3 days. And so in order to even be able to enforce any kind of standards, we need to know where they are and when. And so the thought is if they if they can go into if they have a mobile veterinary registration, premises registration, they can go into their Breeze account, they can go in and tell us the date, the location, and the veterinarians that are providing the service. There'd be no fee for that. It's just automatically. And then there's nothing for my team to do. We just know where they are and when. Dr. McCobb had shared that one of the things that could change is if you have a change in veterinarian at the last minute, which could happen, they would just go in and do another notification, put in the new vet that's there, and they've met the requirements. So the thought again is that it's as easy as possible. We don't want to provide any additional burdens onto them because we want to support what they're doing, but we still need to be able to know where they're at and when. So that would be the board notification side. The other notification, Dr. Waterhouse had recommended for the consumer notice to let them know that these are potentially clean versus sterile surgeries. So that's a consumer notification piece that
But that needs to be further discussed, right? Because of the concerns brought about.
Yeah, so those are the topics left. So if you have any thoughts on those, so we can move on to the next item.
It doesn't happen in a regular veterinary hospital. I mean, I don't know why we would put that burden on them.
So just to clarify, you're just talking about consumer notification right now.
Yeah, sorry.
Because it's
The
not a
other part I'm
sterile
good with.
surgery.
Not necessarily. A cat neuter is not necessarily it could be a clean surgery in a regular veterinary hospital. Out in the middle of treatment room.
Yes. But all the others are not. So we have to tell the consumer that this is.
Oh,
not
but
a
you're saying for
sterile-
the spay.
Yes.
But your large animal veterinarians are doing clean procedures in the field and they're not providing any sort of notice.
No, but this isn't a cow or a horse.
But what's the difference? Why I don't understand why we would need.
Dr. Getkin.
To me, the only thing that makes it, for our discussion, that makes it not aseptic is not having 4 walls. Everything else, they're draping, they're prepping, they're wearing sterile gloves, they're masking, that is aseptic. So technique goes along with the standard of care for the surgical procedure, meaning this surgical procedure, a cat neuter is a clean. A spay is aseptic technique minus having 4 walls, but they're doing all of these things of aseptic technique.
Yeah.
But I thought that was already brought up, the concern about why do we have to define if it's aseptic or clean? Just
Right,
like
right. I don't
Christine
think we
had
have to.
mentioned, earlier, and in a regular, what you call this hospital, we don't say,
Right.
hey, we're doing a splenectomy and it is an aseptic surgery. Oh, I'm doing a neuter, this is a clean surgery. We don't do that.
Exactly, and that's the point. Is
Yeah.
because your client is assuming you're doing that. So they think, clients don't know what a spay is anyway, but they're assuming that you're doing a surgery in a proper way that it would be done.
But it is proper.
But it's not done in a way that it would be done at another hospital necessarily.
What is different other than the four walls?
The four walls,
But that's a facility. That's not a technique.
but that's part of the technique. I can't believe in this day and age, we're having to argue about whether we need a surgery room or not. It's going back 100 years. Why don't we just spay the dog on the kitchen table?
But I
So
don't
we're
see-
talking about the consumer notice, not the room or area at this point. But I think for the exemption for the fees and the exemption and the board notification, it sounds like I got all nodding heads for that one. So we can report to the board. There was a consensus that yes, those are good exemptions to consider. I think where we're not all on the same page is the consumer notification. So maybe we can just do the same thing and you could just say yes or no on the consumer notification, just so we can move this forward. Did you have?
I'm in favor of consumer notification.
Perfect. Then you would say yes. Just-
Okay. Well, I would say any reasonable consumer assumes that a surgery is done in a surgery room.
Yes,
So they have to be told that it's not.
yes.
So, okay,
Did I?
Christy,
No.
Dr. Solcito,
No.
Leah, Dr. Sullivan,
Yes.
Yes.
Dr. Gatkin.
No.
Yes.
Yes.
No.
Cool. So we're split. Which is great.
That's
That's what
okay.
we can report to the board. Do we want to take public comment on the rest of the memo, the straw poll, what's going to be provided to the board? Any
Yes.
thoughts on the remaining?
Public comment.
Nope.
Doesn't look like there's any public comment on WebEx.
This is the moderator. If anyone would like to make a comment on the conclusions, you may look for the hand icon and click that to raise your hand. And each speaker will have 3 minutes with a 15-second warning. Are there any comments on the discussion or conclusion? I do not see any requests. I'll turn the meeting back to you.
Thank you. Okay, are we going on to 5B finally? So we're on to agenda item 5B, and this was something that we were asked to do by the legislature. This was a topic that had actually come to the board several years ago, and now it's back again. And so Jessica had a conversation with the legislators that were asking for this, and I think it was explained to them that we had no control over the remains once they left the hospital to be cremated or whatever, but that we could look for some things that we could do while the body was still in the possession of the veterinarian. So that's what you have in front of you, which I assume everybody has read.
I just want quick clarification. The legislature did not ask us to come up with these specific guidelines. What they were looking at is whether or not the board should regulate pet crematories.
Yes.
During that discussion, we had told them we did not think that this is appropriate for the veterinary medical board to regulate pet crematories because the veterinarian is only involved up until a certain point when the body leaves the premises. But so we didn't think it was right for us to be regulating, but we do acknowledge that things go wrong with the bodies when they're in the facility. So we had said we would look at our premises standards to see, are there things that need to be added to address the concerns that we do see within the veterinary premises? So that's what these are doing. And that was the board's response to the legislature, and then the board asked the MDC to take this on.
Yes, thank you. So has everybody read this? I'm not going to go through and read it all because
The reason why the board.
Microphone?
Directors,
Microphone?
funeral directors and crematories don't want to oversee these cremation services because of religious reasons.
So just a clarification there, it's the Cemetery and Funeral Bureau, and they have not had any kind of official position on whether or not they should. They did have concerns about concerns from their profession, which concerns about mixing animal and human remains. So there, and some of those are religious reasons, but that comes from their stakeholders, not necessarily the Bureau. And then the Bureau also raised similar concerns that we have raised about if you do decide to regulate it, what that's going to do for the cost to the consumer. And to regulate any kind of profession will drive costs up. It's very costly to do. So the Cemetery Funeral Bureau said, we can do it if you decide you need it regulated. That was, and I don't even know if that was an official position, but that's been what was communicated. But if you do that, the concern is it's going to drive costs up, meaning consumers will not actually pay for it, and they'll do other things with their animal remains, such as throwing them in the garbage or burying them in their backyard. And it's not going to solve the overall problem. We don't want to see that happen. So they shared their concerns of if you do this, please consider what that's actually going to mean to the consumer.
I mean, I hear you, and I don't think that we should regulate it, but I think it's an issue. I mean, a person's pet is very precious to them.
Yes.
And if they're sending their pet for cremation, it's very important that they receive their pet's ashes back. And I don't think there's any oversight on many of these crematory services. So can we write a sternly written letter that we think that they should regulate it? And I hear your argument about the cost, but the price of a pet's sentimental value to the owner is priceless.
I don't disagree with any of those statements. Yes, you can recommend the board provide a sternly letter that you do believe it should be regulated. But I just want to keep us on topic for this item because as we're talking about specifically what can be done within the control of the veterinary premises for handling the remains.
I have no issues with the memo.
Okay, thanks.
Okay, so we base this off of 2030.1A, which is already in law, that when no authorization to dispose of their animal, the veterinarian shall retain the remains in the freezer for 14 days. And so then we just kind of took it from there. And so one of the things that we discussed was what starts the 14 days. Of course, in the vast majority of the time, that's a person brings their animal in to be euthanized. You do that, and that's what starts the 14 days. But there are other cases where, other scenarios that can happen. For instance, your neighbor is pet sitting your animal while you're gone to some remote part of the world, and they find your animal dead one day. Well, who knows whether it died the previous day or, 2 days before that or when. So anyway. Anybody have any comments? Yes, Christy. She was first.
I would just say that under section E, number 3,
Page.
page 3, it's actually 3 and on the final draft, I think, but it says disposition service requested by the client. I would add, if applicable, just like it says above under C4, because that's not always known.
Oh, yeah. If applicable.
Yeah. Yeah, because sometimes the hospital doesn't know. Because in services that are, I'll just explain that in services that are sometimes now you're contracted with a service and the body may be picked up and then the provider of with the cremation service then contacts the client directly, and the hospital has no idea what choice of disposition is being chosen by the client. It's all arranged directly through them. And so the hospital has no idea what is being done and what choice the client has made. So just to make sure that again is, if applicable.
Dr. Nunez.
Do we need to define that the holding period starts from the time of death? Or there are pets that are dead on arrival? That could be the start of the holding period. So it doesn't
That's-
matter when they died.
So in the case of somebody pet sitting or, checking on their friend's animal every now and then, you may not know when that
Then,
day of death was.
then the veterinarian's holding period starts
As soon as,
when they come in DOA.
yeah. Or I think we said as soon as the veterinarian started to, from the time the veterinarian started to try and notify the owner.
Oh,
I guess we need to clarify that the holding period, let's say it's not the owner who brought in a dead dog, right? The holding period actually starts after the owner had been contacted. You cannot start it immediately upon receipt of the remain. As long as there is an like attempt to contact. I mean, that's, I think, part of making sure that it is the owner who's giving permission rather than just a good Samaritan, or even if it's hired.
contact or contact?
So contact.
So in the case of somebody who's in a very remote
Documented.
part of the world, it can't be contacted.
Yeah.
Oh, attempt. Yeah, sorry.
Attempted.
Documented attempt.
Yeah, so I'm looking at page 11 and we're in A, and it's making some proposed changes to A to clarify when the start of that 14-day period. And it has, we are changing body to deceased animal in a freezer at least 14 days from the date the veterinary premises made a documented attempt to contact the client prior to disposal.
No attempt to contact.
Correct.
So you could get a DOA, but the holding period doesn't start until you attempt to contact the owner.
Correct.
Dr. Gedkin.
So that means if I do a euthanasia at my clinic and the client is like, I don't know if I want individual or communal. And I'm like, okay, I'll give you time, and I hold the pet. The 14-day waiting period doesn't start until I contact them?
You've
No,
already contacted
You've already-
them. You've already
Got
talked
it.
to them.
So made contact. Okay, attempted to make contact. Okay.
You can tell them in a nice way. They have 14 days to decide.
Another thing we discussed was the alternative disposition services. Yes, that was a complaint to the board at one time. The veterinarian wanted to use one service for cremation and the owner wanted somebody else, but they were already contracted with one.
That was one area where I had a question. I see where we're adding that, but would that require the veterinarian to have a full list of all the available services available for someone that says, I don't want, okay, I just don't want to require the vet to have more, because the way it's written, it sounds like the veterinary premise shall release. Oh, no.
we can make
Shall
a
notify the client that
recommendation.
there may be alternatives. So maybe the language is loose enough so that, okay.
All it's letting him know there may be other services
Yeah,
out there.
no,
It's not
first.
requiring him to do the research themselves or provide a list of anything. It's just, there may be other services available. Let me know if you want to use their service. We have a contract that we use, but if you want to use someone else, you can. That's all it's telling them, because we received complaints that the veterinary premises is requiring them to use that service and won't release the remains unless they use that service. So clearly, it sounds like from the veterinarians that that's not something that should be happening. And so we wrote language in there that just says, letting the consumer know there may be others in the area. Feel free to do your research.
Dr. Gedkin.
So letting consumers know can mean a sign in the waiting room, a form that this client signs upon consent. We're not defining
We're
how.
not requiring them to get a form to consent. We're just saying at any point, letting them know that there may be other options out there. Basically just preventing them from saying you have to use this company.
Right, so we're not saying written, like,
Yep, doesn't say that.
so I can just say, I gave him verbal instructions that he could take the remains to wherever he wants. We're not saying it has to be okay.
Yes, Kathy.
Speaking of disposition, and maybe this is implied here, when you're in the 2030.1, adding section E, the list of things is noting whether it's a private or group. Now, what Christie said, I didn't realize, I've always been asked, do I want a group or private cremation? Shouldn't that be part of the list of information maintained on the of the deceased animal? Or is that the term disposition service? I thought that just meant cremation versus disposal or something. I didn't know it meant
That's what that
type of
means.
cremation. Okay, perfect. Oh, can I ask one more question stupidly? Isn't it already illegal for a deceased animal that during the holding period to be used for unauthorized purposes that the client hasn't agreed to? I mean, I know we've seen, I know in some of the disciplinary thing, there have been one-off situations, but isn't it already against the law? It sounds like we're adding this in during the
I think
whole.
we're making it clear now.
Is this making it clearer in case they didn't know? Okay, thank you.
So another thing that we debated was then when in the case where the veterinarian gets the ashes back, how long should the veterinarian be required to hold the ashes before they dispose of the ashes? So we settled on 6 months. What do you think?
50 years.
No.
The longest I've held is 5 years.
6 months seems reasonable.
6 months seem okay? Okay, great. Anything else?
Other states that had
Smells like,
requirements?
Step by step.
Did you research that?
No.
what was the question?
If there were other states that required,
Oh, well,
Bonnie, do you know, there are any other
For
states
records
that
of
require
ashes.
anything like this?
Yeah, we can research that.
Any other comments or suggestions on
Whole language?
the whole, yeah. Yes, Dr. Gatkin.
I have a critical question. The log, the transfer custody log, documenting and signing off and then signing off and then bringing back ashes and signing off. It seems like the rationale or the amendments are to address the scenarios where the veterinary premises improperly codes the remains for group cremation or otherwise loses the remain. The thing is with the log, you're just going to go off the first piece of paper that says communal cremation, right? So once I make the mistake upstream that I mark it for communal and it's not, you're just logging what I said. And then we're just, right? There's always going to be one primary. Is further documentation actually going to prevent what would likely be a human error? Because how we log, how we document, right? You're just going off of the first thing. Is that actually going to?
I'm sure it won't correct all errors, but it should help.
So the subcommittee had the discussion of human errors are going to happen. This is not going to prevent all errors from happening, but and subcommittee, correct me if I'm wrong in my understanding, but it sounds like it's pretty standard for all veterinary premises to have a sort of log for the tracking the custody of the remains, but that is not standardized. And so the recommendation was, let's make that at least standard. And the thought was, if everybody at least has this log in place, then there is a standardized process to hopefully help prevent these things from happening, because everything that we had talked about has actually happened.
So if that's the case, I'm just thinking ahead. We don't have a requirement to even have a client sign that they want communal or individual, right? So what if a complaint comes through that they say, I want an individual and they did communal, and I'm like, yeah, they said communal, because there's not even technically a requirement to have a client say, I want communal, right? So I'm just thinking ahead with consumer complaints. If I'm like, my log says communal, and the client's like, no, I want it individual. And it's like, well, I didn't even have to have a consent
The way,
sign,
the
right?
way that I look at it is like medical record keeping, right? It's the same thing. If you did something or you told the client that I'm going to give your dog a shot of diphenhydramine and they approved it, right? And then later on they come back and say, I never approved it, right? So it is really about the log being part of kind of a medical record that you have to trust that the communication is being reflected appropriately. Mistakes will happen, as we've known. As you said earlier, like you would just go by with what is written on the first, but the thing is, that is the break in the communication right from the start that the body was received. Whoever received the body already made a mistake of writing down communal versus individual, and that will be carried through the entire,
And most hospitals have
Right.
different fees for group cremation
Mhm.
versus private cremation.
Mhm.
So the invoice itself could be a log.
Mhm.
Yeah.
Yeah. I guess this is more of just like helping clarify things and making sure that we have records. Because based on what my conversations are with some practitioners, they don't even write like complete like information. They just write down the name of the pet and that the date that it was euthanized, and then it gets put in the freezer. Now, when it was picked up, who picked it up, who received the cremains, they're never really tracked. So this is more of us just adding different layers for protection.
Thank you. Any other comments? Any public comments in the room?
Can we do maybe a motion first?
Okay,
And
motion
then a public
first.
comment?
Yeah, sorry. Is there a motion?
On page 5, in case you're wondering.
I know if you make it, then I can second. I'm here. So I will make a motion to recommend to the board to approve the regulatory text and attachment 2 to amend CCR Title 16, Section 2030.1. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review. And if the board does not receive any comments, providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, then the board authorizes the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If after the 45-day public comment period, no adverse comments are received and no public hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulations as described in the text notice for CCR Title 16, Section 2031.1, and I forgot to say as amended today. Thank you. Sorry, I forgot that.
I second the motion, and I think that Christie should be our official motion maker.
I think so too. I agree. Okay, now public comment. Okay, any public comment from the room?
Bonnie Lutz, I just have one comment. You're calling that new record a log. And I think that's confusing because a log is an ongoing record, like a DEA log.
We
So
meant
it's
log,
actually,
it's not part of the medical record, sorry.
okay, but that's my question,
Oh,
is to me, it should be part of the medical record. Because if it's a log, you can't really keep a log 3 years after the entry because a log is an ongoing thing, like a DEA log. You keep adding to the log. You'd add different clients to this same ongoing document. And that's what a log is. And so this is actually then, the way I'm looking at it, part of the medical record for that individual client that then you would keep for 3 years. I just think that should be clarified because if it's called a log, it's going to confuse the issue. Also, you didn't discuss the responsibility shifting to the veterinary premises. Are you going to discuss that?
So this isn't back and forth communication, but we
I
can
know.
go to that.
Okay.
Any other public comment? Any public comment from WebEx?
Hi, this is a moderator. If you would like to make a comment, you may look for the raise hand icon typically at the bottom of your WebEx screen. And if you are joined us through a mobile device, you can click three dots behind the other option. We'll give you 3 minutes with a 15-second warning. I see no raised hands. I return the meeting back to you.
Thank you. And Jessica, you want to explain?
Sure. Just overall clarification, the intent from the subcommittee was to indeed keep it a log and not part of the medical record. From their perception that this is due, every veterinary clinic is maintaining some sort of log, and they didn't want to have to actually tie it to individual medical records. So they intentionally made them separate. And as far as that, knowing when to keep it because it's ongoing, you would essentially, because they had this discussion, was you have a log and you hit that for that year mark. I think we did the 3 years. You don't have to keep it anymore. But the thought is intentionally to separate it from the medical record and have it a true log. So that was intentional. As far as the shifting to the veterinary premises, this committee decided what it wants to discuss. As far as the memo goes, and it sounded like everybody was okay with the memo, but yes, it absolutely does shift the owners to the veterinary premises. We were thinking if we are already in this regulation, you might as well make that shift now. We are looking at the bigger picture, as everybody knows. It's for the ownership, the responsibility of the minimum standards to the veterinary premises owner. But yes, this is shifting that to the veterinary premises owner at this time in this regulation, because the discussion was it's really the veterinary premises that is in charge of this, not the individual veterinarian. So yes, it does make that change. Question?
Yes, Dr. Sullivan.
We had a euthanasia log forever, from beginning to, whether ashes came back or, that whole thing was in a log. It wasn't in the medical records.
Correct.
Would it go on a hospital inspection list?
So it could be, if this is something that's required, that would be something that we could easily ask for the inspector to look to make sure that they have a log, similar to making sure they're maintaining their drug logs.
Okay. Oh,
We're ready for a vote?
are we? No more questions? Thank you. Okay, call for the vote.
Ms. Bowler.
Aye.
Dr. Gedkin.
Abstain.
Dr. Nunez.
Yes.
Ms. Pulowski.
Yes.
Ms. Felt.
Yes.
Dr. Solocito.
Yes.
Dr. Sullivan.
Yes.
Ms. Esri.
Yes.
Dr. Waterhouse.
Yes.
Motion carries.
Do any other board members have any thoughts on my belief that cremation services should be regulated by the Board of Cremation, by the way?
Oh, a letter?
I know why that's skipping back a little bit.
So the question is, would you like to recommend to the board to do a strongly worded letter in encouraging the regulation of pet crematories
By the Board of Funeral Directors.
by the Cemetery Funeral Bureau?
Yeah.
Oh, can I just, yeah, as a consumer and somebody who listened to the testimony when it came before the board several years ago, I really would like to see some entity, not this board, because it's not in our purview, but I think the funeral and cremation, whatever it is, should review this, because these animals are members of the family. It's heartbreaking enough. And when you hear things and horrible situations and there's no recourse for these consumers, I think that's very sad. And these cremations cost quite a bit of money now. Well, my dogs are huge, of course, so I get the jumbo price, but they're very costly. And when you have horrible things happen, there's nobody they can turn to. And it isn't the vet's responsibility. It is the crematorium or whatever the company is called, right? So that's my opinion. I think we should, I hope the board does do something.
Dr. Sullivan.
Yes, there is recourse. It's civil court. And I would not recommend any letter that may come back to haunt us, so I'd keep, yes, I would
Yeah,
like to keep it quiet.
Yeah.
you ask for.
Yeah, it could.
And that, I second that. Well, I'm not, it's not a motion, but I'm just saying, I agree with that comment with Dr. Sullivan. I worry that anything that we do would come back to us as a board, and that it can come back and say, well, then good luck. And so I do. And as a consumer protection agency, right? Not just as a board, because I worry that what happens is it gets passed to the consumer then, because then the prices of cremation go up even more. And we all know that the price of cremation is sometimes prohibitive, and it's very scary. And I think that that can get passed on to the consumer, and that, and I worry about that even more.
Any other comments? Okay, let's come back at 3 o'clock, take a break. (3 p.m.) We're back from break. And we're on to agenda item number 6. Update and discussion and possible action on the Veterinary Practice Subcommittee, Dr. Sullivan and Marie.
Okay, I will start with 6A here. In July 2025, the board directed the MDC to explore requiring veterinarians to transition to electronic medical record systems that automatically date and timestamp entries. They also asked the MDC to consider key challenges, including the cost of implementation, as well as barriers for rural and large animal practices. This initiative was driven by ongoing enforcement issues related to poor record keeping, such as a lack of continuity of care, medication errors, altered or inconsistent records, and cases where records were only discovered after the fact. The subcommittee began by surveying all AAVSB jurisdictions to determine whether any other state or Canadian province required electronic medical records. Of the 9 jurisdictions that responded, none had this requirement, though a couple of jurisdictions did note that they wished they did, as it would solve many enforcement-related issues. The subcommittee also looked at requirements for human health practitioners. In California, there is no legal requirement to use electronic records, aside from those required for e-prescribing. However, at the federal level, the American Recovery and Reinvestment Act of 2009, through the Health Information Technology for Economic and Clinical Health Act, promotes the adoption of electronic health records. Rather than mandating their use, the law provides financial incentives for providers who use electronic systems meaningfully and imposes penalties on those who do not. We did come up with some sample language. If the board chooses to move forward with requiring electronic records, the subcommittee recommends adding the new subsection H to CCR section 2032.3 to define what written record means in PC section 4855. Based on the board's parameters, the subcommittee drafted the following sample language. H, on or after the date, 2 years from the effective date, written record shall mean an electronic record that includes all information as required under this section and is entered into an electronic practice management system. The record and any amendment created pursuant to this subsection shall include a system-generated date and time stamp. Minor amendments would also need to be added to subsection A for clarity. Since there is a pending rulemaking related to records, the subcommittee amended the attached language as attachment 1 for easy reference. This language would add a reasonable transition period to allow time for veterinary premises to research practice management systems that best meet the needs of each practice. There is no proposed exemption for rural or large animal practices. This is because no specific time frame is required for entering records into the electronic practice management system. Veterinarians working in the field may document notes by hand and enter them into the system later. Notably, BPC section 4855 requires that a copy of the written record be provided to the client within 5 days of receiving a request, or sooner in certain circumstances. To comply, rural and large animal veterinarians would have at least 5 days to enter their notes into the practice management system. To help assess the potential impact on the profession, the subcommittee invited stakeholders to participate in a meeting regarding this potential requirement. The invitation also included a brief 3-question survey. Do you use an electronic practice management system to create and maintain your animal patient records? If yes, what is the name and cost of the practice management system? And does your practice management system date and timestamp each entry? Prior to the stakeholder meeting, 137 individuals responded to the survey. Of those responses, 73% responded that they do use a practice management system, and 75% of those systems date and timestamp each data entry in the record. Survey results indicated annual costs ranging from about $800 to $24,000, not including additional expenses for hardware, software, and data migration. Because of concerns about the reliability of those estimates, the subcommittee followed up directly with the most frequently cited companies in the survey to obtain more accurate pricing. They also explored whether AI scribe platforms could serve as a lower cost alternative, but found they were not viable since they do not meet the date and timestamp requirements. Attachment 2 offers a complete breakdown of the findings for reference, but as a summary, 8 companies were contacted, one of which was no longer on the market and will only offer support for existing systems. Based on the current veterinary premises data, roughly 80% of veterinary premises are considered small practices with 1 to 3 full-time equivalent veterinarians. As such, the cheapest option for most veterinary premises that meet the minimum data and timestamp requirements is roughly $2,400 per year. Approximately 70 individuals participated in the stakeholder meeting. Most were focused on how the requirement would be implemented and what compliance would look like. As expected, the primary concerns came from small independent veterinarians who indicated the cost could force them to close their practices or retire early. There was also concern that software companies might significantly raise prices if the requirement is adopted. The subcommittee has no formal recommendation. We are asking that the MDC and the board discuss the information provided in this memo and any perspectives shared during this meeting today and the board meeting. Please also consider how long the transition period should be if the board decides to initiate a rulemaking. If, after considering all information provided, the MDC recommends the board move forward with the requirement, there is language for a motion available on page 4 of the memo.
Thank you. Dr. Sullivan, anything to add?
Not to add, Marie did most of this work, so she's the expert in it. I did have a question. When we use the term electronic practice management system, is that synonymous with the PIMS, or can it refer to a different system?
I think in practice, it's generally synonymous with the PIMS, but I don't think we have
I've
any
always taken it.
definition,
Okay.
official definition.
I'm a little uncomfortable with linking it. That's why I was asking. There is another way that I have seen, and this could be done by an individual who's using a Word document or even some type of a scribe program that leads to a Word document that then could be time-stamped with a software program like Adobe. I have a Adobe Pro, I think it's like $200 a year. And it's clunky though, to get every document time-stamped is a little bit onerous, but it can be done. And I would think if we're looking at a time frame of 2 years after we get it through regs, that could be 4 or 5 years down the road. A lot of things are going to change in that period of time. But I think we have some leeway if we're looking at a 4 to 5 year frame or timeline to get this all finished. So I think it's a good idea, but I do think it looks like 30% or 30% of our members are not on a digitalized record system. So that's a pretty good number. My thoughts.
I just want to add on to Marie's answer to your question. So there's no definition for practice management system, and when when the two of you had discussed, there was an understanding in the industry of what that means. When it comes to enforcement wise, as long as in the situation that you described, Adobe, that if any amendment created in any entry, if it's date and time stamped, it would fulfill the written requirement. But there's not a definition of practice management system. The key is what that system is doing, if it meets what H is.
Kathy?
Of course, in all the practices I've been involved with all my animals are particularly large generally, and they're all on electronic record keeping from intake all the way through. But I worry about, although when Dick said two, the regs take years. I was thinking maybe 2 years was a little too short because some practices that they're going to have to buy equipment, printers, PCs, laptops, iPads, whatever they're going to need. And depending how big they are, we just want to give them the ability to be able to invest in that. It doesn't sound like it's a completely cheap operation that we're requiring here, especially with the difference in the pricing and everything else. Now, it may get less over time. That could be true, but I just thought is 2 years too soon. So anyway, that was my only thought.
And to clarify, it's 2 years from the date of the effective date. So if it does take a year, then that would be a year. And then from the effect, so you're looking at it takes a year for a rulemaking after the board approves it, which arguably could take longer. But if it's a year, then it would be 3 years before it actually is effective.
But people pay attention once it's in effect.
Right.
Comment? Any other comments? I can tell you, I work as in addition to all the other things, I am a consultant for the Veterinary Medical Board. And so I look at complaints that have been sent in. And in looking at the respondents' medical records, in the last 10 cases I've done, 3 of them I suspect were fraudulent, that they just totally rewrote the whole record. They were not electronic. But I can't prove it. One I just suspect. And so I said no departure, but one, there were some other, other inconsistencies. So a couple others, there were a couple more inconsistencies. So I sent it on to a subject matter expert to have them see what they think. But I think this is a problem that they may be figuring out, that you just totally rewrite the record. They won't know.
Records I submitted were not talked to.
It's okay that they didn't hear you.
Okay, well, we need some discussion or indication whether you're for or against requiring electronic medical records
We need discussion.
for a recommendation.
Make a motion if nobody is going to do this. So, okay, go.
I just have a question, clarification, actually. So when we're talking about electronic medical records, this includes those handwritten records that are digitized or like scanned and added on, correct?
So it would have to be, there's 2 things. Just digitizing them doesn't necessarily solve the problem there, because you need to have a timestamp for each entry. So that wouldn't necessarily meet that criteria. So I just wanted to clarify that. And then I do know in the stakeholder meetings, there are concerns about, well, what about all of our records? Are you now going to require this to be up, once this becomes effective, we now have to get all of our old records and then make them and put them into this practice management system. No, that's not what this language would require, because it's not applied retroactively. So it would be as soon as it's effective from here on out, then they have to have them electronic records. Just scanning them and making them scan doesn't solve for the date and timestamp entry issue, and also
Even
doesn't-
if the date and time are included in the handwritten record?
So the other piece of that issue is the handwritten part of it. That's what makes it so, sometimes they're so illegible and they're so hard. Where even though there's a requirement for them to be legible, they're just not. And so that creates a huge issue when it comes to continuity of care. And we see errors for medications because of the illegibility, which is another big piece of why to make it into an electronic management system, not just scanning a handwritten record. That wouldn't get to the crux of the issue itself.
I just have a concern from what I heard during the stakeholder meeting of those folks that are on the fringes, basically, that have declared that they don't work with computers. They still have written records, and declaring that if this is something that is going to come to pass, then they will just have to stop practicing, right? And they said also, unfortunately, these folks that I would say technology is something that's kind of difficult to kind of be embraced, especially for a certain generation, right? But the thing is, these are also practitioners that are servicing areas that do not have other, practitioners in the area. So I just wanted us to maybe look into what we could possibly do to get to our goal of electronic records, but in the meantime, also, how do we facilitate this folks on the fringes? So,
Yeah. So I attended the stakeholder meeting too, and I think the person you're referring to that said, if this comes to pass, I'm just going to retire. But her biggest reason is she uses only Apple. So it's not that she wasn't computer literate, but she only uses Apple products. And most PIM systems are compliant with that. She can find something that would work, but it's not the most common PIM system. Christy. Oh, sorry. Yes.
While we're talking about stakeholder comments, I also wanted to point out that it was brought up in large animal medicine. There are some government forms, some state forms, for example, brucellosis vaccines, trichomonas testing, that are only available in a handwritten form. A lot of those forms are sent to the lab for testing, so they have to be legible, because if the lab can't read them, then they can't result them. But there are going to be a few situations where a scanned document is going to have to be acceptable for things like that, where there is no alternative for a state record.
But those could be, the reports could be scanned in, correct? You can scan in a report, you just can't have the.
So again, if I'm understanding from the board's concern is two-pronged. You have the potential that you need the date and timestamp, the entry of every one, but then the goal is to get away from the handwritten record.
Right.
So
But if you have something that is handwritten, a report or a prescription or something that is handwritten, you can scan that into the record.
But then,
Yes.
So if you scan it in, you're still scanning a handwritten record.
You're just scanning a report.
It's a lab form. It's a lab form that becomes part of the medical record. That's what I'm understanding. It's like you're scanning in a lab form, which is common practice even in small animal medicine. From my understanding of what you're saying, Marie.
Yeah, the brucellosis vaccination portion is not a lab form. That's
right.
That's a vaccine record. But
right. Yeah. But it's a vaccine record, but it's just like a lab form that they use in small animal medicine, and they have to scan it into the medical record, but it's still, that would require them to actually document it in part of the medical record that it is done as well. So it's kind of like they're going to now have to do it in two form.
Yeah, but that's common. Okay. Yes, Leah.
Well, I just, my question or concern was also for large animal or rural. I know that this paperwork says there wouldn't be any exemptions because they have up to 5 days to enter their handwritten notes. But if the whole point of it is date and time stamping those, wouldn't those notes be inaccurate date and time stamped if they weren't done at the time of the visit? Or how does that, right? I mean, it's the same thing maybe for small animal practitioners that write their records at night, but that's, I mean, just something I was thinking about.
So it's my understanding, just in any large or small animal, when you're treating the pet and you're doing the medical records, even if it's the next day, because you don't have time to do it, you're not saying that you did the surgery the date that you're doing the records. You're saying that you do the surgery the date that you did the surgery, right? So I think that's what matters.
Yes, Christy.
So, yeah, I mean, I'm so conflicted on this. I gotta get away from this microphone. I'm so loud. I'm so conflicted on this, but I also look at this as this is, I too did the Kathy thing and I did the math and I was like, oh, 2 years, right? But then I did the Dr. Sullivan thing and I was like, oh, but we're making law, so that means we're years out. And so I went back and forth, and there are people that we have to recognize that are serving underserved communities, and they may be technology, there may be those that are technology challenged. But I also feel that we are giving 3 years notice minimum, minimum. That's if the law went into effect. I mean, we like passed this, immediately. And so I really feel like to protect consumers, that's what I'm going to go back to. We need to make sure that the medical records are legible and that they cannot be altered in any way. And the time and date stamp is so important. And it's not just because doctors or veterinarians or staff are trying to do this fraudulently. It's because they just don't think sometimes. And they think, oh, I need to add this. And they don't think about, oh, I should have done that in an addendum. And I just think that this is what's best to protect consumers and pets. And so this is the right thing to do. And I really feel like Dr. Sullivan said, there are ways that it can be done without putting a financial burden on people. And I think that the things that, yes, there are excuses, we can come up with excuses for anything, but this is the right thing that needs to be done. And I think it's the right thing for consumers and pets. And we can find excuses all day long.
Yes, Dr. Sullivan.
I move to recommend to the board approve of the regulatory text in attachment 1 to amend CCR Title 16, Section 2032.3, and direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review. And if the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, then the board authorizes the executive officer to take all steps necessary to initiate the rulemaking process, make any technical and non-substantive changes to the package, and set the matter for a hearing if requested. If after the 45-day public comment period, no adverse comments are received and no public hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulations as described in the text noticed for CCR Title 16, Section 2032.3.
Thank you.
I'll second.
Okay, moved in second.
I had a comment. There's one section that says there's no California laws requiring human health practitioners to use electronic records with the exception of the requirement for e-prescribing. And I remember when that exception was made, it was because of the cost that veterinarians would have to take on to participate. Now that we're requiring all veterinarians to have electronic records, that wouldn't jeopardize this exemption, would it?
It's a legal question here.
Well, I mean, I think you're asking if this were to take effect, is it going to have impact on the existing laws? Right now, there's an exemption for veterinarians. So the only thing that would risk that is if someone then proposed a law change to then so that would require statute for others to then say, well, veterinarians shouldn't have this exemption anymore. So, I mean, that's a risk today for because there's, when it comes to statutes related to all healing arts, there's oftentimes carve-outs or exemptions for veterinarians. So at any time, someone could say, well, I don't think veterinarians should have that exemption. It's a possibility. Is it likely that veterinarians are on everybody's radar? I don't know.
So if we picked on the funeral board, they might come back Get this out.
They're a bureau and I recommend not picking on anyone.
All right. So you don't think it would be an issue?
I said, I don't know. It could happen. But I think that's a lower risk.
Okay, I think Dr. Sullivan has a comment.
Yeah, I want to amend the motion mainly for discussion. And that is to say that this rulemaking enactment cannot happen before January 1st, 2031.
Oh,
So then the amendment would be on or after January 1st, 2031.
okay.
Before I accept your friendly amendment, can I ask why? I mean, okay, before I ask your amendment, I didn't mean friendly, but it's because it's not friendly. I'm asking for like, can I ask why?
I think it needs a second before we can discuss it.
Okay, is there a second?
She did second it.
Oh, okay.
That's why I'm asking
Okay,
why.
well, because I don't think 3 years, if it really goes quickly, I don't think 3 years is enough for that population that we heard on the, and we're talking about 25%.
5 years is good.
So this is a minimum 5 years.
Does everybody understand what's going on?
So if you look at on page 2 where we have the sample language, instead of where it says in brackets right now, it has date and then it has example 2 years from the effective date. Instead, it would say on or after January 1, 2031, and then continues. I just need to know if Ms. Pulaski agrees with that amendment.
I was thinking, math is hard, people.
6 years.
Yeah,
5.5 years.
I will accept the amendment.
So at this point, there's been an amendment and a second to the amendment. There should be board discussion, public comment, and a vote.
Okay, more discussion, Kathy?
Well, I just wanted to, I thank Richard, Dr. Sullivan. I agree. I mean, I think this is a better time period to allow people to find the resources to purchase what necessary equipment. And no matter how long it takes, they never pay attention until it's in effect. And giving them only 2 years, I think, was a little short. So I appreciate the change in language.
Dr. Gedkin?
I have two things. One is not having to do with this, but is in the proposed thing. But just even if it is ongoing after 2031 and someone has educated themselves on this expense, and one thing is still access to care because the ongoing cost will get likely shifted to the consumer. So that's just something to keep in mind for the future. The second thing I had is actually on the language in the proposed regulatory that I think is getting voted on, a technical question on page 8 is when we're talking about point 5, treatment and intended treatment plan. When we're doing 5B, and is this part, I just want to make sure, is this part of it or not?
No, so this is
Never
not,
mind.
that's not part of the discussion. Only in what's in blue is part of the discussion.
Got
The
it.
other stuff is already
Got it.
going through.
Any public comment from the room? Any public comment from WebEx?
This is the moderator. If anyone would like to make a comment on the motion, you may look for the hand icon and click that to raise your hand. Each speaker will have 3 minutes with a 15-second warning. Are there any comments on the motion? I do not see any comments. I'll turn the meeting back to you.
Thank you.
You're welcome.
Okay. We ready to vote?
Ms. Bowler?
Aye.
Yes.
Dr. Nunez?
Yes.
Ms. Pulaski?
Yes.
Ms. Chappelle?
Yes.
Dr. Solocito?
Yes.
Dr. Sullivan?
Yes.
Ms. Esri?
Yes.
Dr. Waterhouse?
Yes.
Motion carries.
Is this the amendment or the main motion?
So it's the main motion. You amended the motion to include that date. So
Okay,
everything's covered.
all right.
Just so the record is clear, the question that was called was on the amended motion. So that motion carried.
Is there a report on CDFA for 6B?
Order, does that mean that we have to vote on the main motion then?
No, you amended the motion. So so you voted on the all the language as amended,
Okay,
essentially.
all right. That's not what I heard the attorney say, so excuse me.
Don't cause trouble on your last meeting.
Okay, 6B, is there a report from CDFA or about CDFA? Dr. Sullivan?
Thank you. We met virtually on Friday, April 3rd, attending the meeting where Jessica and Matthew from the Veterinary Medical Board, Dr. E.D. Marshall, Dr. Stephen Beam, and Dr. Brady from CDFA, and Marie and myself from MDC. Stephen Beam, PhD, introduced himself as the new director of CDFA, who has replaced Dr. Jones after her retirement. And from his online bio, and I'm quoting, Dr. Beam earned his BS and master's degree in animal science from the University of Nevada, Reno, and his PhD in animal science from Cornell University, conducting research primarily in dairy cattle. This was followed by a postdoctoral fellowship in the Department of Animal Science at UC Davis before joining CDFA in 1999, unquote. We were really happy to see him attend the meeting. It was great to meet him. Jessica began the discussion by introducing the topic of mandatory CE related to judicial use of antimicrobials. Interesting enough, Dr. Marshall and I were at an AVMA meeting the day before with their committee on antimicrobials, where the very same topic came up. The committee is made up of people from producer groups, federal agencies, and AVMA staff, whose main mission is antimicrobial stewardship. However, the members on this committee are leading experts in the use of and regulation of antimicrobials, most of them with advanced degrees or experience in research on antimicrobial use and resistance. Dr. Marshall is a great contributor to this committee, whereas most of this discussion is way above my pay grade. Most of my position on this committee as board liaison, where my pay grade is just to listen. The discussion on the day at the AVMA and at our meeting at CDF came down to discussing mandatory requirements of CE. My feeling was and is, if it's important, the only way to get that message out to all veterinarians is a CE requirement when it is part of the required CE and not an additional requirement. There is always pushback when you make anything mandatory. However, I think the mandatory requirement we have in California is accepted very well. There were also comments made about it in the standard of care in disciplinary cases as a way of getting compliance in practice. That seemed a little less efficient to me. Jessica updated the committee on the requirements of electronic medical records discussion that the MDC and board is having right now. Dr. Marshall attended the virtual stakeholders meeting that we had recently. We also received an update on the blood banks and the regulatory process seems to be moving smoothly. I believe they said that it is in OAL at this time. And Marie and Jessica can add or correct anything that I just presented or answer any questions. Thank you.
Thank you. On to agenda item number 7.
We have to open it for discussion and then public comment.
Public comment. I'm trying to, you can tell it's 3:30. Yes, Kathy.
the CDFA, the blood bank update. Did they talk about what, in terms of the private blood bank, community blood banks, what that production is? Do they have a percentage?
They did not at this meeting, but I think at a recent one, it was pretty low.
Really low. Yeah, okay. Thank you. Just wondered if there were any upticks.
No.
Any other questions, comments? Any public comment from the room? Any public comment from WebEx?
If anyone would like to make a comment on the issue, you may look for the hand icon and click that to raise your hand. Each person will have 3 minutes, and we ask that people speak once per agenda item. Are there any comments? I do not see any requests. I'll turn the meeting back to you.
Thank you.
You're welcome.
So on to agenda item number 7, update and discussion from the Enforcement Subcommittee. Dr. Gedkin.
Thank you. And if you guys can just turn your attention to page 3 of the memo, we're going to just go over our figures. As indicated in attachment 1, from July 2025 through March 2026, consultants reviewed 553 cases, of which 301 were determined to be no violation. 21 were found to be educational opportunities, 20 had insufficient evidence, and 211, which is 38% of cases reviewed, were determined to need a full expert review. This means board consultants resolve 62% of the standard of care cases without the need for a full expert review report. This is right? Okay. In that same time frame, the board closed 202 cases involving an expert review, with 84 closed as no violation. 66 closed with an educational letter, 40 closed due to insufficient evidence or other, 3 citations, and 9 disciplinary actions. Based on this data, around 94% of cases closed involving an expert review did not result in a citation or discipline against an individual respondent. The average number of cases reviewed monthly by experts this fiscal year is around 22 cases, which is slightly down from the average of 25 over the prior fiscal year. Similarly, the average number of cases reviewed by consultants is 61, which is slightly down from the prior fiscal year average of 65 cases. The number of cases pending expert review rose slightly from the prior meeting, coming in at 607 cases against 429 respondents. As mentioned during the prior meetings, board staff is proactively requesting records for all complaints as they are submitted, resulting in a steady increase in the number of cases pending consultant review, now at 1,469 against 1,214 respondents. This number will continue to rise as staff continue to request records for all standard of care complaints, which are then added to the consultant queue. Roundtables were held on February 25th for consultants and February 26th for experts. The consultant roundtable had all 6 consultants in attendance, and the expert roundtable had 16, not including the consultants' experts. Beyond some hypothetical standard of care scenarios, a variety of review points were covered, including explaining why a respondent's rebuttal to a potential violation doesn't change the opinion of the expert, covering in the findings whether an action of failure to do an action led to the negative outcome, touching on a sample document showing differences between passive and active voice in writing, avoiding using the title of board expert inappropriately, not using gold standard and sticking to the standard of care, restating that any standard of care departures found should be noted in the report, not providing a subjective opinion of the respondent, and timely response when it comes to reports and response reviews. Due to the lack of public enforcement cases finalized since the prior board meeting involving a current expert, no cases were reviewed by the subcommittee.
Thank you. Any questions from the board? Yes, Christy.
Can you just tell me like what the use of board expert inappropriate, like what an example of that? If there like, is there, no? I saw the no, okay. Okay.
I think if you were going to use it in the context to try and like induce something from, let's say you're a vet and you go to a clinic and you say, oh, I'm a board expert, you should do this, and you're using it in a way that's inappropriate. Like undue influence that's inappropriate. You can say it as a fact that you're an expert for the board because it's true. But I think if you're using it to, sway somebody's opinion in an, inappropriate way, that's the concern.
Yes, Kathy.
You for the report. Is 56, is that a pretty good number for SMEs, or is it low, medium, high, what we currently have?
I believe it's the highest we've had.
Oh,
So,
that's great.
yeah, so it keeps going up and we have some more waiting in the wings, but obviously the reviews aren't exactly where we need them to be. The number's gone down a little bit, the average, when we're looking at it. So we're looking at some other ways to do things, and some of those experts that maybe aren't available to pull them in to help out with the consulting as well. Since we do have a pretty large bucket of cases waiting consultant review, we can maybe call on them to do that, because there is a lot more involved when you're reviewing a case as an expert versus a consultant. And as many of you know, a lot of them don't have maybe the time to dedicate to reviewing a full case, whereas they can just maybe filter one relatively quickly.
I do want to clarify that that's the number of contracted subject matter experts we have, not necessarily the number of subject matter experts that are currently taking cases. So it's about half of that.
Right.
Any other questions? Any comments from the public? Any comments from the public on WebEx?
This is the moderator. If anyone would like to make a comment on the report, you may look for the hand icon and click that to raise your hand. Each speaker will have 3 minutes with a 15-second warning. Any comments? I do not see any raised hands. I'll turn the meeting back to you.
Thank you.
You're welcome.
Agenda item number 8, update and discussion from the unlicensed practice subcommittee.
Okay, it's been a long day, and you've served this committee and this board for many years, Dick, but I do expect your full and complete attention to my report.
I have a lot of questions.
On Thursday, March 26th, the unlicensed practice committee consisting of Dr. Maria Solicito, Dr. Mark Nunez, and Executive Director Jessica Sieferman visited the Desert International Horse Park in Thermal, California. Thermal is located just outside of Palm Springs and close to the Coachella Valley. The temperature that day was 100 degrees Fahrenheit. Kudos to Dr. Solicito, who drove out all the way from Palmdale that day and picked up Jessica at the airport. The subcommittee was invited to tour the facility and meet with management to discuss reports of unlicensed practice, specifically at polo events. The subcommittee met last year with several managers of various polo facilities in the area to discuss the issue and to identify ways to work together to reduce this activity and increase compliance. This meeting was a follow-up to that previous meeting. One of the challenges identified at the last meeting was the difficulty in overseeing the practice of veterinary medicine due to the sheer size of these horse parks. In the 100-degree weather, we were given a walking tour of the facility by one of the veterinarians who worked there, and it was massive. It was huge. Some of the other polo facilities host the Coachella Music Festival, and so these are large acreage places. Our visit happened to have fallen near the end of the polo season, so many of the temporary stables were being taken down at the time. But at the height of the season, the facility is capable of boarding close to 3,000 horses.
Wow.
And just as we were walking around, there were horses everywhere with riders everywhere, very well dressed, and other team members just doing various activities. So it's like, I felt like it was a city, a horse city, or Disneyland for the horses, because there was just everything happening all at once. This particular horse park hosted mostly equitation and hunter jumping events rather than polo matches, but they did do a few polo matches. To serve the veterinary needs of the horses, the facility has 4 full-time veterinarians on site, and I believe it was 2 RVTs. they're not employed by the horse park. They have their own practices, their own premise permits, and of course licenses, and they charge for their services. There's also a pharmacy on site that fills written prescriptions. It's owned by another veterinarian. We haven't reviewed any of the premise permits or for the practices or the pharmacy, but it might be prudent to do so at some point. We don't have any reason to believe that any unlicensed activity is being done by the veterinarians and RVT that work there. But we were told that many of the teams that participate in these events bring their own veterinarians or contract out with outside veterinarians for their horses and veterinary needs. And this is where most of the unlicensed activity is occurring. The facility was gated, and on the day of our visit, there was one entry point with a security guard checking for passes. A recent change that has been made at the park is that every person that enters must have previously filled out an application online to receive a pass. The pass has their name and information, but it also has a space that you can fill in why you're there. So you can be there as a rider or as a trainer, or most important to us, as a veterinarian. Presently, the application doesn't ask if you are a California licensed veterinarian. It just says, are you a veterinarian? We asked if they would be willing to include that information on the application form, and they said it would be an easy thing to do, and they would make the changes soon for that. The entry badge is mostly a small little wallet-size card with a barcode. It doesn't identify the person as a veterinarian. So we asked if they would consider creating badges similar to name tags that identify a person as a veterinarian. So if a horse owner receives veterinary care, they can see that it's a California licensed veterinarian that's performing the services. We also asked if it could be possible to remind that all DVMs and RVTs practicing veterinary medicine at the park require a veterinary license. Owner exemption rules may apply. Because some licensees may not know this. It all could be a matter of education. Some veterinarians may believe that since they hold a license in another state, that reciprocity laws automatically apply and they don't need a license here. So they're going to consider adding that requirement in the application form or the entry badge. The badge check-in program offered another potential opportunity for enforcement in that on any given day, an attendance sheet could be generated that would list all the veterinarians and RVT at the park on any specific day. The park said that they would be willing to share the list with us to check how many California licensed versus unlicensed practitioners there were on any given day. This doesn't prove unlicensed activity, but it would give us useful information. Management also said that many practitioners who are licensed in other states are aware that they need a California license to practice, but felt that the application process was too difficult and that the fees were too high. We can't do much about the fees, but we did discuss our reciprocity policies and BREEZE programs, making the application process a lot easier than it may have been in the past. And that it was agreed that this was an opportunity for education that we can jointly work together on. There was a veterinarian whose practice was on premise, joined the meeting late, and prior to his arrival, the manager of the facility pretty much was saying that he wasn't aware of much unlicensed activity that was going on, but when this new veterinarian joined, the discussion, he flat out said right away, yeah, there's tons of unlicensed activity going on, but the board can't do anything about it, so why enforce it? He said the fines were minimal and that because his statement was they're not licensed by the boards, the board has no authority over them. So Jessica explained our recent changes to our fines and how our fines have a little bit more teeth to them now, and that with unlicensed activity, we definitely do have the authority and ability to assess fines to people who are not licensed. They don't have to carry a California license to receive a fine. He also reported instances of unlicensed activity that his wife reported to the board, and the board did nothing. At that point, Jessica whipped out her phone and checked on the complaint and determined that the complaint was received, but in many of these cases, it was received anonymously and there wasn't much detail to the activity. And because of that, we just couldn't complete the process. And we just reemphasize that that's a big concern that we have with this unlicensed activity, particularly in this horse community where it's a close-knit community and it's just kind of known that this happens. Dick, I see you yawning over there. Are you paying attention? We discussed the difficulty in processing complaint with too little information, and we acknowledged the difficulty in reporting unlicensed activity. In such a close-knit community, at some point, the veterinarian that joined the meeting late said the board needs to make money, and that's why we were here. He then stated that he used to be on the board back in the 80s. We told him that although the board members' salaries are probably just about the same as they were back in the 80s, our primary goal is for consumer protection. We also discussed that much could be accomplished by just educating the consumer and the licensee population. The consumers at this park may not realize the requirements for a practicing veterinarian to hold a license. And that comes with, and what comes with that, educational standards, continuing education, knowledge of regional diseases and laws, recourse when things go wrong, and more. The value of these horses is tremendous, and they may have insurance policies that cover medical expenses and other expenses. The topic was raised that if during an insurance review of a medical claim, it was discovered that an attending veterinarian did not hold a California license, how would this affect the claim? That seemed to really grab their attention when we made that point. As stated previously, many of the complaints received involved polo events. And although there are several polo grounds in the area, we were not able to visit them. Visiting them in the future should be a goal of this committee, to continue to educate consumers and licensee holders to see how similar or different their opportunities were in the park we visited. Other areas to explore is to reach out to governing bodies that oversee many of these events. So they talked about the U.S. Equestrian Federation that oversees lots of the rules and regulations of the events, and then also the Olympic Committee that has their own standards. At one point, one of the managers says they're the ones with the real teeth, and then if they speak, then this population will listen. So perhaps a goal of the committee is to reach out and open up a dialogue with those organizations to see how we can work together to remind them of our regulations and rules. Overall, I applaud the efforts of the members of this community. They've engaged in an open discussion on the issue of unlicensed activity. However, depending on who we talked to, there was various opinions on the extent of the activity. As I was leaving the facility, I used one of the porta potties that was there, and I found taped to the inside of the door a flyer that was advertising laser services and other physical therapy by certified veterinary technicians. That was a clear example of unlicensed activity. I didn't have my phone to take a picture of it, but it's there. That's my report.
Well, thank you, and thank you for doing your investigative work and driving all that way. Thank you.
Do you have anything to add?
I just think that walking 7,000 steps in 100 degrees heat was worth what we were able to achieve, because I think it was very clear that management was not aware about a lot of things. And I can only imagine, because of how massive the facility is. Actually, they have 10 stables that houses 1,000 horses
Wow.
per stable. Yeah, so it's like, by the time that we got there, some of them were already emptied out, but at some point in time, they really have a lot of horses there. And so, and I guess their openness to work with us, just like with the tracking of, licenses and providing information. I think we did really good. I also think, as Jessica had suggested, we probably need to have more presence more frequently in their events, just so that they don't get forgotten, so.
We also talked about maybe next season to have an informational booth there at some point, just to spread the word.
Dr. Sullivan.
Yeah, I'd like an explanation on the owner exemption. So how is that documented, and do we have any level of?
I think that if an owner brings their own veterinarian and maybe the veterinarian doesn't charge for the services, then they might believe that that falls under owner exemption.
Does not charge for the services?
Yeah,
Or if he just
So
works
he's
for
working
his
for the
hours.
owner.
yeah.
Yeah.
That
Is that
that was kind of briefly mentioned. But that was the thought there, that they're not charging for the services. So it's an agent of the owner.
So just, I'm going to take a step back. I think there were potentially some confusion on the track of whether or not the owner exemption applies. And so there would have to be, there's discussion about outreach materials of where that line is and when that owner exemption may apply. But also about that outreach of, you have veterinarians who may not be licensed in California, they're licensed out of state, or they're licensed in another country, who may not know that they have to be licensed this is from them, not from me. And so it would be helpful if some of our outreaches is, you're licensed in another state, here's how you get licensed here. So to provide that pathway, because there's a lot of misunderstandings of what the requirements are to be licensed in California, so we can create outreach material for that. But yeah, there are questions about when the owner exemption is triggered and when it's not, and then where that line is of when you're consulting versus where that line is of, you need a license because you're doing more than consulting. So there's questions of where that is. And so there was a request for clarification and some outreach materials designed on where that is.
Yeah, and I really think there's a lot of opportunities with working with the USEF, because they really seem to pay attention to those rules and regulations. So if we can get the USEF to tell them, pay attention to the board, I think that would be a good opportunity.
So the example I heard a number of years ago was that, and this had to do with dairies, where the veterinarian works full-time at that dairy, that they did not have to be licensed, but they're making, they're an employee of the dairy. Is that?
If they're employee, they're using that bona fide owner exemption.
Yeah.
And the bona fide employee of the owner, that is triggered.
Okay, and couldn't this also happen with the equine veterinarian?
Potentially. There's a lot of different variations of who's doing what, and I think they're all trying to use the owner exemption. So I think depends.
And we only visited one park, but it didn't seem like at this park, the veterinarians had their own practices. They weren't employed by the park. They had their individual practices.
And I do want to clarify, I did not confirm or deny that we received a complaint against an individual. That's not public information. What happened is that he had made a claim that his wife has made several complaints to the board about a specific individual. And what I could tell her is we do not have any records of her filing a complaint against an individual. But I also explained in general how we are seeing with anonymous complaints, that if someone does an anonymous complaint, we can't then discuss that complaint with any individual or acknowledge that a complaint has been received, because it's not public information. But then I discussed the challenges that we have with anonymous complaints in general, particularly as it relates to the equine community related to racetracks, horse shows, and polo clubs. In that industry, we typically get a lot of anonymous complaints that says so-and-so is doing XYZ without any kind of evidence or anything that we can actually go and try to prove. And we have to have something. We do have a lower burden of proof when it comes to issuing a citation, but it's still a burden of proof. We can't just go in and take action based on an anonymous person that we cannot then ask questions for.
Yeah.
We can't take action, nor should we be able to take that action. We have to have some kind of evidence. And when they do an anonymous complaint, then we have no one to follow up on. It makes it really, really challenging to do anything with. And we do our best. Sometimes we can do, depending on what the information is, sometimes we can do it undercover. But if we do it undercover, especially in this scenario, in this atmosphere, everybody knows everyone, and the ones who are using unlicensed individuals are doing it knowingly, and they're okay with it. So it's not like I can send an undercover person in to try to catch them in the act, because these individuals know who everybody is. So it makes it really challenging. So it's really just having that communication with the veterinarians who are really upset about this happening. And when they say, well, I filed millions of complaints with the boards and they're not doing anything, having that dialogue with them to explain to them the challenges that we're facing and what we actually need, I think is really going to help. I think just having that conversation with them and talking to them about the things that we need, I think is going to make a huge difference. And they're encouraging us to have more of a presence, and just merely having a booth there and talking to the consumers that are there, talking to the veterinarians that are there. It makes it more uncomfortable for everybody to be okay with the status quo of the unlicensed practice.
This place was so big, it had restaurants and bars and stores within the fence.
Wow.
It was like a horse city.
Any questions, comments? Any comments from the public? Any comments from the public online?
This is the moderator. If anyone would like to make a comment on the subcommittee report, you can look for the hand icon and click that to raise your hand. Each person will have a 3-minute speaking time with a 15-second warning. Any comments on the report? I do not see any requests for comment. I'll turn the meeting back to you.
Thank you.
You're welcome.
Agenda item number 9, update and discussion from the outreach subcommittee. Kathy.
Thank you. Mine will be much shorter than Dr. Nunez's, as I didn't write out 20 pages, but I commend you. And actually, it sounds like there may be some opportunity for the outreach committee to help with education as per what you have been working on in the equine stuff. So look forward to doing that. The outreach committee, it's this very short. We've done one thing last summer, probably, or late spring. It was brought to the board's attention through some individuals, and there perhaps might have been complaints too. There might be some concerns about canine reproductive services being provided at dog shows and other animal events, and whether all of that is being done within the guidelines of the Practice Act, et cetera, et cetera. And working with the board staff and legal, we came up with some language and a flyer and materials to talk about reproductive services, which start with, semen collection to sort of the diagnostics of the semen validity, and then freezing, storage, AI, all the other stuff that goes along with it. And we put put some materials online, it's come to our attention that there may be some confusion in some of that language. And we definitely don't want to make anything confusing to consumers and or inaccurate. So we're going to try and edit some of that language before we do any more distribution. We do have a list of all the kennel clubs in the state, which are the ones that produce the dog shows under the auspices of the AKC. And when we clean the language up and get it so that it's tightened up, we will be getting that out probably in the next couple of weeks to the kennel clubs. And look forward to input from folks. And hopefully it's all about educating consumers about the safest and the most appropriate way to work with canine repro services throughout the state. So that is what we've done. And then the other thing is PACVET is meeting in mid-June here at Golden One Center and the conference. And Jessica will probably speak to it more, but apparently there's going to be a booth. There's going to be a seminar on spectrum of care. There's going to be another seminar on sort of the workings of the board. And a third one? Was there three, Jessica, that we'll be participating in?
Yeah, so we're doing a few things when it comes to outreach. We're working with any kind of large continuing education events, PACVET being one of them. I reached out to CVMA to see if they were willing to compass a booth there at their event. So we have an event there, or a booth there during the first 2 days of the event. And then on the third day, we will be providing 3 continuing education presentations, one on inspections and misbranding from Dr. Howard. We'll be providing one on an overview of the board, similar to what we provide to students and local BMAs on the enforcement process as well, talk about common violations and ways to avoid them. And then also the third day is going to be on the spectrum of care being the standard of care. And having that discussion of where we're at. So there's 3 discussions, presentations that we'll be providing at PACVET.
And that's my report unless Dr. Waterhouse would like to add anything.
No, good job. Any questions? Any comments from the public in the room? Any comments from the public online?
This is the moderator. If anyone would like to make a comment on the committee report, you may look for the hand icon and click that to raise your hand. Each speaker will have 3 minutes with a 15-second warning. Any comments on the report? I do not see any requests for comment. I'll turn the meeting back to you.
Thank you.
You're welcome.
On to agenda item number 10. We're almost done. My committee chair report, and I've shortened it up since we talked about a lot of this today. The VMB at their January meeting approved changing the VCPR to patient-specific instead of condition-specific and forwarded it as a legislative proposal. They also approved a legislative proposal for the shelter veterinarian licenses and practice exemptions. The executive committee of myself and Kathy Bowler and Jessica met on February 23rd and March 30th, and we discussed mainly the status of the subcommittee's work. On February 26th and March 12th, I met with Jessica and Dr. Solicito to talk over our HVSN and our animal remains issues. And on March 6th, I did attend the stakeholder meeting on EMR, as I mentioned before. There are 3 remaining rulemaking packages that stem from the MDC going through the process. Number 1 is the records, CCR section 2032.3. Number 2, civil penalties for citation, CCR section 2043. And number 3, RVT pathways, CR sections 2068.5 and 2068.6. All 3 will be submitted to the DCA in April or May, and public comment is scheduled to start in July. In addition, the board discussed the concern raised by the enforcement subcommittee related to veterinarians charging for prescriptions and/or the time it takes to verify a refill request. They directed the MDC to research this further and bring recommendations to the board at a future meeting. The other pending MDC topic is separating the MGL responsibilities from the premises minimum standards, instead placing responsibility of the minimum standards on the premises registration owner. As an FYI, tomorrow, the board will be interviewing MDC candidates for the various vacancies At a minimum, the MDC will at least one new veterinarian member and one new RVT member in June, as Dr. Sullivan and Ms. Schufeld has served 2 full terms, are not eligible, how sad, for reappointment. At this time, I would like to thank both of them, Dr. Sullivan, Leah. Thank you so much for your dedicated service. And I invite the board president to present resolutions from the board to both of you.
For this part, I guess we could do, if we could ask all the board, the MDC members to stand by the seal so that we could have a photo taken after the awarding of the board resolution. Yeah. We start. Okay. Dr. Sullivan. So this is a resolution from the California Veterinary Medical Board. Whereas Dr. Richard Sullivan, DVM, served as a member of the California Veterinary Medical Board's Multidisciplinary Advisory Committee from April 17, 2019 to June 30, 2026. And whereas the California Veterinary Medical Board recognizes and commends Dr. Richard Sullivan for his exemplary contributions and unwavering commitment during his tenure as member of the MDC. During his 7 years of service on the committee, 2 of which he served as chair and 1 as vice chair, Dr. Sullivan was at the forefront of every complex state and national issue. He served on multiple subcommittees and task forces, where he was instrumental in crafting regulatory and statutory language related to veterinary medicine, protecting consumers and animals, promoting professional standards, improving licensing and enforcement processes, and was integral to the board's consumer protection mission. And whereas Dr. Richard Sullivan's distinguished service in these roles has significantly advanced the California Veterinary Medical Board's mission and vision, setting a high standard for those who follow in his footsteps. Now, therefore, be it resolved that the California Veterinary Medical Board and Department of Consumer Affairs Acting Director Christine Lally, by token of this resolution and behalf of the state of California, express their deepest gratitude to Dr. Richard Sullivan for his wisdom, leadership, excellence, dedication, invaluable contribution, and exemplary service during his term on the Multidisciplinary Advisory Committee. And be it further resolved that a suitably prepared copy of this resolution be presented to Dr. Sullivan. Are we taking a picture together?
Let's do Leah's.
Okay.
We can take pictures after adjournment.
Okay. I thought it was an individual. Okay. Leah, there we go. California Veterinary Medical Board Resolution, Leah Schufelt. Whereas Leah Schufelt served as a member of the California Veterinary Medical Board's Disciplinary Advisory Committee from May 23, 2018 to June 30, 2026. And whereas the California Veterinary Medical Board recognizes and commends Leah Schufelt for her exemplary contributions and unwavering commitment during her tenure as member of the MDC. During her 8 years of service on the committee, 1 of which she served as chair and 1 as vice chair, Leah Schufelt served on multiple subcommittees and task forces. She was instrumental in developing regulatory and statutory language related to veterinary medicine and the work of registered veterinary technicians, and took up the mantle for numerous issues impacting the profession and consumers. She was essential to the board's consumer protection mission. And whereas Leah Schufelt's distinguished service in these roles has significantly advanced our mission and vision, setting a high standard for those who follow in her footsteps, now therefore be it resolved that the California Veterinary Medical Board and Department of Consumer Affairs Acting Director Christine Lally, by token of this resolution and on behalf of the state of California, express their deepest gratitude to Leah Schufelt for her wisdom, leadership, excellence, dedication, invaluable contribution, and exemplary service during her term on the Multidisciplinary Committee. And be it further resolved that a suitably prepared copy of resolution be presented to Leah. So now requesting all the MDC members to please.
So perhaps before we do that, we can finish her report, take
Oh,
public
okay.
comment, adjourn, and then take pictures.
I just want to take a picture.
She loves her pictures.
Yeah, yeah.
Yeah.
She loves
Okay,
her
I'm done with my
pictures.
report. Any comments? Any public comment?
You love your pictures.
Any public comment from WebEx?
This is the moderator. If anyone would like to make a comment on the issue, you may look for the hand icon and click that to raise your hand. Each speaker will have 3 minutes with a 15-second warning. Are there any comments? I do not see any requests for comments. I'll turn the meeting back to you.
Thank you. Okay, number 11, future agenda items and meeting dates.
All right, so Dr. Waterhouse already mentioned some pending MDC assignments that's separating the MGL from the registered veterinary premises. We have charging prescriptions or the time it takes to refill prescriptions. Another thing that was discussed at the MDC, but I still need to have the board direct the MDC to do, is looking at, there was, and I think it was in October, a question about animal control officers and their ability to, for euthanasia, if they can carry controlled substances, and the potential concern about conflicting with federal law. So that was something from the MDC. We just need to have the board directing to the MDC to look at that further. And then another thing that came up today during public comment, and I don't know if the board would want to, or the MDC would want to ask the board to continue, was a concern about anesthesiologists in California and the ability for RVTs to practice ultrasound guided regional anesthesia. And then anything else that the MDC would like to add to the agenda for the board to consider having the MDC work on. And then as far as meeting dates go, they're all online. The next ones for 2026 is July 14th and October 13th, and then all of 27 are posted as well. Any
public comment on that?
Yes.
Any public comment on that? On the dates? Any public comment on WebEx?
If anyone has any comments about conflicts or anything about the dates, you may raise your hand for comment. We do have a request for comment from Stefano De Concerto. I'll send you a request to unmute your mic.
Yes, thank you. Hello. So I brought up the issue of the clarification on ultrasound guided regional anesthesia. I do not know exactly how this process works and how and when will I have a confirmation of whether this topic will be discussed at the next meeting, and if so, am I allowed to present a brief PowerPoint to explain the issue as I saw done today for the MASH and high volume spay neuter clinics? Thank you.
Okay, yes. Any other public comment? And Dr. DiConcetto, we will be in contact with you.
And he is muted at this time. My apologies.
Okay.
I do not see any further requests for comment, so I'll turn the meeting back to you.
Hey, and now we can adjourn and take a picture.